We have a wonderful, very full program for you today, full of a lot of great information. So you'll be pleased to know that all of the presentations that you will see will be available afterwards on the DiCE website, as will the recording of this, so you can watch it again to capture some of the great insights that we're going to be sharing with you. We have 2 hashtags that we encourage you to use for your social media, and you'll find them at the top of your screen. That's DiCE CRC Screening Summit and CRC Screening Summit. And that helps us follow the conversation on social media and see what you found interesting and useful. So let's get on with the program. And I'm delighted to introduce our first speaker, and to open this formally, it's Eric van Kusten, who is from Digestive Cancers Europe, co-founder in Belgium. Eric, the floor is yours.
Thank you so much, Tamsin. So my name is Eric van Kutsem. I'm professor of GI oncology at the University of Leuven, the head of the department over there. And I'm a gastroenterologist and a GI oncologist. And on top of that, one of the positions is I'm co-founder of DiCE. Why is this summit so important? Well, this is important because if you look from my practice, if you see many patients, a couple of thousands of patients with different GI cancers, you realize how important it is to go for early diagnosis. And the model, one of the cancers where we can work best on early diagnosis is colorectal cancer. That was also the motivation why, with different working groups, we did over the last 20 years a lot of efforts to implement screening in Europe. Patients deserve that. Politicians are aware, but there was still a big need and gap to try to implement that. We've been successful in some countries. More and more countries are successful. And in the 2 previous colorectal cancer screening summits, we've been discussing that, some of the challenges for the implementation, some of the knowledge, the gaps in our knowledge. And the implementation of screening is extremely relevant. If I give you, for instance, the example in Belgium, the screening is within the regions. Flanders, which is 60% of the population in Belgium. I had the privilege to start up and to be responsible for the screening program, how it will be done in Flanders, till we started in October 2013 with screening. And if you look, for instance, at some recent numbers, of those patients being diagnosed with colon cancer, and if the cancer is diagnosed within the screening, the official immunologic fecal occult blood testing, the FOBT, if the cancer is diagnosed within FOBT, within the screening program, 2 to 3% of these cancers are stage 4. For those cancers detected and diagnosed outside of the screening, in Flanders, more than 20% are stage 4. So you see the big discrepancy. We see a big stage migration within programs that are running quite well, not perfect. We have a participation of 50% in Flanders. On top of that, 10% of the population gets a colonoscopy. So that means that we reach about 60% of the population. And with that, we see an important stage migration. So that's just a pragmatic example of what can be achieved with screening. So it's important. It's important also from the patient point of view in this setting. There are still a lot of problems. We see an increasing incidence in some countries, at least a younger population, 20 to 40%, 40 years. In the US, if we define the younger below 50, 10% of the patients with colon cancer are below 50. In Belgium, it's at the moment 6%. Some other countries, it's between 6 and 10%. But we see an increase in the younger population. We don't have a clue why this is. This is a population, if they don't have risk factors, familial risk factors, that we don't reach with screening programs. There we should try to go for predisposition, hereditary predisposition, but that's not always the case in these younger patients. So we will be able, if we can do a good screening program, make progress, decline the colorectal cancer mortality. Today, if you look in the best countries in Europe, the 5-year survival rate is between 65 and 70%. That's not only due to screening, that's also due to progresses, innovation, progresses in the treatment. So it's a combination of different aspects, but screening is relevant. And that's what it's all about, that I wanted to tell you as an introduction, as a motivation, as a clinician, and clinical and translation researcher involved in many GI cancer projects, to give you the motivation to continue to try to implement screening on all levels as good as possible. And that's why I'm so committed also to DiCE. I'm so proud of the team of DiCE, led by Zorana Marovic, who is doing a great work. And one of the, let's say, the key points in the strategy of DiCE is to work on screening and the awareness of screening. And that's why we're having this colorectal cancer summit. Thank you very much.
Thank you very much, Professor, and again for highlighting that we could do better, that the difference between catching people early through CRC screening and just other ways, it has a huge impact on the stage of cancer and the patient outcomes, and also the ongoing open questions, which is unclear why certain younger populations are getting CRC cancer earlier. So thank you now, and I'm going to pass the floor to Lieve Werink, who is going to share her story and is also a leader within the CRC movement and DiCE. Lieve, the floor is yours.
Thank you very much. Good afternoon, good morning. My name is Lieve Werink. I am a former colorectal cancer patient, a former member of the European Parliament, and the current chair of Digestive Cancers Europe. Firstly, I would like to thank you for taking the time out of your busy schedules to meet us today. It is my great pleasure to welcome you for the third time at the Colorectal Cancer Screening Summit. I am proud that we have created a series out of these events. Why do I say that? Because I am sure many of you have attended dozens, if not hundreds of conferences, whether online or in person. They all set a problem, provide policy solutions, and then call to action. With colorectal cancer series happening every year, we are aiming to dive into the details, to talk about practical solutions, present the latest science and developments, and yes, of course, hope for better policies that will make implementation of colorectal cancer screening easier. This year, we are especially excited as this is the year when, after 2 decades, European cancer screening recommendations will be updated. When it comes to colorectal cancer, I must say we will not be having a revolution. But then, why would we need one when, as we will hear in the presentations, and even the current recommendations still need to be fully implemented? We are often all looking to the future, proposing new policies, white papers, etc. But today, I would like to go through a bit of a process of reflection with me. In preparation for this summit, I had a look at a text from 2003 cancer screening recommendations. It stated that in 1998, as a reminder, that is before a session of Central and Eastern European countries, so the EU 15, colorectal cancer were estimated to be cause of 14% of all cancers. Fast forward to 2020, and colorectal cancer in EU 7 accounted for 12.7% of all new cancer diagnosed and 12.4% of all deaths due to cancer. That made it the second most frequently occurring cancer after breast cancer. and the second cause of cancer death after lung cancer. Therefore, we are welcoming the European Commission ambition in the new cancer screening recommendations that 90% of the EU population who qualify for colorectal cancer screening are offered screening by 2025. We believe that, as suggested in the Commission's proposal, using fecal immunochemical testing, the FIT for short, for colorectal cancer screening instead of fecal occult blood screening as the preferred triage test for the referring individuals aged between 50 and 74% for follow-up colonoscopy could improve uptake of screening. We are committed to working together with the European, national and local stakeholders to make it happen. Thank you all, and I look forward to our discussions, but most of all, of our actions. Thank you.
Thank you very much, Lieve, and it's wonderful to see you and see your continued passion for leading the colorectal cancer screening activities. As you know, Lieve was a member of the European Parliament, and obviously when she was there, she was able to fly the flag for cancer screening. And now we have two messages from current MEPs who are friends and champions, and they would like to share their messages. Let's start with Sarah Cerdas, who is a member of the European Parliament from Portugal and the Vice Chair of the MEP Digestive Health Intergroup. She's a member of the ENVI and the COVI committees. Let's watch her message.
Hello everyone, my name is Sara Cerdas. I'm a medical doctor and I'm currently a member of the European Parliament and Vice Chair of the MEP Health Group. I would like to welcome you to the third DiCE Colorectal Cancer Screening Summit, and I'm very sorry not to be able to join you live, but rest assured that I'll be following very closely the results of the summit and also with great interest. As a member of the European Parliament, in this regard, I hope that the European Beating Cancer Plan will deliver on its promises to European citizens. And one of the core initiatives is the update on the cancer screening recommendations that are currently due to be launched by the Commission. I am aware that EU recommendations and guidelines are one thing, but the reality that many patients face is sometimes far away from those that are European policies or what we aim with the European policies. For instance, and I'll give you some examples, despite the EU screening recommendations since 2003, it is still the second cause of cancer death in men after lung cancer and the third in women after breast and lung cancers. And obviously this is quite concerning, and the impact of colorectal cancer cannot be ignored. In this regard, on diagnosis and incidence, we have that colorectal cancer is also the third most diagnosed cancer in men after prostate and lung cancers, and the second one in women after breast cancer. Despite this, and because of this, my colleagues and I in the European Parliament will continue to work to ensure that the European project delivers not only on its economic promises, but also on its social promises. To that end, we will strive to ensure that cancer recommendation implementation will be followed up by appropriate resources. We will not be afraid to follow and to expect the best from the European Commission on how it supports member states in implementing cancer recommendations. This is of utmost importance for less affluent countries, where we can see a clear west-east divide in mortality when it comes to colorectal cancer. For instance, the 5-year survival rate of colorectal cancer patients diagnosed between 2000 and 2007 is highest in Western Europe and lowest in some countries of Eastern Europe. We cannot allow for inequalities in screening to create inequalities and disparities in cancer mortality. This is not to be accepted in the European Union. With this in mind, I wish you all a fruitful and inspirational debate, and I look forward to working with you to ensure that colorectal cancer screening is quite well implemented across the EU. Thank you very much for having me here to be able to get you some words, and I wish you all a very great summit.
Thank you very much to MEP Sarah Surdis, and as you probably well know, she, with her medical background, she's very strongly interested in health and is very active and very visible. We also now have another message from an MEP who is well known as a champion for health, and that's Deirdre Cluner. She's from Ireland and she's from the EPP group, and she sits in the IMCO and COVID committees, and she's a substitute in the ENVI committee, which of course has lead responsibility for public health. So let's watch Deirdre's video message.
Good morning, everyone. My name is Deirdre Clune, Member of the European Parliament for the Ireland South constituency. And I'd like to thank Digestive Cancers Europe for inviting me to speak at this event today. And I'd also like to offer my apologies for not being able to attend via online video link. As you know, colorectal cancer accounts for the second highest number of cancer diagnoses in Europe, with this figure predicted to rise in the coming years. Ensuring widespread colorectal screening across Europe is essential. As a member of the Special Committee on Beating Cancer, BECA, which works to address cancer at the EU level, I've seen firsthand how important it is to support researchers, doctors, nurses and social workers in providing real assistance to patients fighting cancer and those who have recovered from it. Our work on cancer treatment at the EU level is not only an expression of our solidarity, but also our responsibility for the well-being of our fellow Europeans. I assure you we have my full cooperation in bringing about changes to support colorectal cancer patients. For colorectal cancer, the new EU cancer screening programme will involve screening triage testing for those aged 50 to 74. The inclusion of screening for lung, prostate and gastric cancers will together expand EU-supported screening to cover screening for cancers which collectively are responsible for 55% of cancer diagnoses in Europe each year. Furthermore, feedback from patient groups has made it apparent that educating healthcare professionals about the early signs of colorectal cancer is a necessary step. However, we cannot stop at diagnosis. Patients must receive continued support throughout their journey with clear, understandable information provided about the treatment options and the available support services. Again, this is where increased education and cooperation with healthcare professionals is vital. Communication between colorectal cancer patients and healthcare professionals is crucial for effective supportive care, and as has been outlined in your report, many patients are not receiving complete information. Discussions like those that we're having today are necessary to raise awareness of the challenges faced by colorectal cancer patients and to implement solutions to improve the detection and treatment of colorectal cancer. At an EU level, we must encourage Member States to implement a set of concrete measures to strengthen the prevention and treatment of colorectal cancer. Early detection gives patients the best chance for successful treatment. So investing in and expanding cancer screening saves lives. I hope that the rest of your morning proves successful, and I thank you for your time.
Thank you very much to Deirdre Cluner for that message. And again, the clear, strong message that the European Parliament is interested in seeing the results of this and is committed to see that across Europe we meet the best in class in terms of what we can offer citizens for our colorectal cancer screening. I'd now like to introduce the last person on our panel of welcome, and that's Dr. Andrei Ilbawi from the WHO, and he's the technical lead for cancer control in the Department of Non-Communicable Diseases. Dr. Ilbawi, welcome. Please, the floor is yours.
Thank you, Tamsin. Thank you also to Digestive Cancer Europe. It is really our pleasure to be with you today. I'd like to begin by appreciating the moving words by Liva. Cancer is a personal disease. It affects nearly every country and every family in those countries. If we focus the cancer agenda on people that are directly experiencing it, meaningful progress can and will be made. Thank you, Liva. By the end of the summit today, nearly 1,000 people globally will be diagnosed with colorectal cancer. More than half of them live in Asia, and half of them will unfortunately die from their disease often without access to quality care, financial protection, or even basic palliation. This is not acceptable. By 2040, the burden will double, and the fastest rise in the colorectal cancer cases will be in settings least prepared to manage this disease burden. What is particularly frustrating about the situation is that we have the essential tools to prevent, screen, and treat colorectal cancer. But unfortunately, there's been a disconnect between knowing what works and implementing what works. It is clear, as we've heard from the esteemed speakers already, we know what works. As an example, nearly every normative agency in Europe and the Americas recommends colorectal cancer screening in settings with strong health systems. Yet only 14% of EU citizens between 50 and 74 years participate in screening programs. So what are the implementation challenges? What explains this? First, a lack of enabling services or public health programs that maximize access to care and participation in screening services. Second, profound inequalities, as we've heard from the MEPs, within and between countries. These are both linked to stigma. They're also linked to the social, economic, and political determinants of health. And these implementation challenges aren't unique to Europe. They exist in communities in every country from Asia to the Americas. Certain populations are at risk, and certain populations are neglected. But in Europe, you have a strategic advantage. You have a once-in-a-generation opportunity. You have a roadmap with the EU Beating Cancer Plan. You have the political and financial investments within the EU Beating Cancer Mission, and you have the technical capabilities. More than anything, you have a strong civil society voice. These are the foundations of success. So how can we move forward together for the betterment of Europe and for the betterment of communities globally? First, we must innovate with a focus on equity. That is through social and organizational innovation. To date, most of our attention has been drawn towards technological innovation. For example, a lot of focus is placed on new products to detect cancer through liquid biopsies or through advanced imaging. These are indeed important innovations. They are necessary, but not sufficient. Without community-led innovation that improves equity, technologies will remain unused by populations in need. Fundamentally, we must shift our focus towards social and organizational innovation. As a simple example, in the US, when vulnerable populations were offered decision aids linked to a dialogue with their healthcare provider, screening participation rates were as high as 70%. That is compared to 27% in a control group. Yet these types of interventions don't get media attention, they don't go to scale, and they are unfortunately not prioritized. Why? Because we do not empower community-led change, and we focus too much on technology. Second, we must shift our advocacy to address the stigma and misperceptions related to colorectal cancer screening and treatment services. This builds trust with communities, and with trust comes behavioral change. I'm also a cancer surgeon, and I work in Africa and in the Americas. One of the most devastating situations is when a person refuses treatment for colorectal cancer simply because they do not want an ostomy, even if it is temporary. This is a total injustice to a large community in need. As many and nearly 10% of a population will have an ostomy in their lifetime. But we simply do not acknowledge their lived experience. We neglect the broader survivorship care needs of people affected by colorectal cancer. This is particularly disappointing because we advocate to reduce stigma after many cancers and after many cancer treatments. But we don't speak words of empowerment for people affected by colorectal cancer. Let us go back to the strong voice of we. If we focus our agenda on people affected by colorectal cancer, we will succeed. This is our take-home message. This is our inspiration and our motivation. Dear friends, this is a unique moment of global solidarity. The global health architecture in cancer is at its strongest point yet, and this is particularly true in the EU. This is our opportunity to generate momentum, to come together, and to focus the agenda on people directly affected by colorectal cancer and access to services. Millions of lives depend on us. Together we can, and indeed together we will succeed. Thank you.
Thank you very much, Dr. Ilbawi, for your very inspirational message and your emphasis that the role that civil society, such as our community, could play in moving the needle so that we can deliver better services, and also challenging us to look at the way we can innovate in our organization and our outreach and communication, because this is critical to ensure that people actually access what is in place, because we still have some way to go before we've met fully the potential of the resources that we have in place. So thank you very much, Dr. Ilbawi. We're now going to go to our first panel, and this is going to look at how we update the screening recommendations. And both of our previous speakers have spoken about the fact this is a once in a generation window of opportunity. So what do we need to learn from the past so that we can improve colorectal cancer screening programs for the future? And to take us through it, we have Professor Iris Lansdorp-Vogelaar, who's the Associate Professor at the Department of Public Health at the Erasmus Medical Center in Rotterdam, Netherlands, and she's representing EU-topia. Professor, the floor is yours.
Thank you very much, Tasmin, and thank you very much to the organizers for giving me the opportunity to express some of my views on colorectal cancer screening in Europe and what we can learn from the past to improve the future. Let me see, yes. Although not exactly the starting point of colorectal cancer screening in Europe, I think many of you would agree with me that the EU Council recommendation in 2003 really was the kickoff for colorectal cancer screening in Europe. This recommendation included colorectal cancer screening as one of the 3 cancers to screen for. And I think there are 3 important aspects to this Council recommendation that we should keep in mind for the rest of the panel discussion today. The first is that it should offer evidence-based cancer screening through a systematic population-based approach with quality assurance at all appropriate levels. And for colorectal cancer at that time, the evidence-based approach was the fecal occult blood test. Then a second important aspect at that time was that the screening program should be implemented in accordance with European guidelines on best practice, if they existed, and that further development of best practice for high quality cancer screening programs should be facilitated. Well, 4 years later, there was a first report on cancer screening in Europe. And this slide shows a picture on the status of colorectal cancer screening in Europe at that time. And although I agree that, yes, indeed, it's only 4 years since the launch of the EU Council recommendation, I would still like to argue that the picture that this graph paints is quite bleak. At that time, so 4 years after the recommendation, there were no countries that had nationwide population-based colorectal cancer screening programs. No countries. And actually only 4 countries at that time were aiming to achieve such a program. And you can see those countries colored completely in the light blue. So that were Italy, France, the United Kingdom, and Finland. And actually, at that time, there were 8 countries that had no planning, no piloting of colorectal cancer screening at all. And I must admit that actually the Netherlands was one of those countries. So we also did not report very quickly after that. But also very interesting are the countries that are in red. They are offering colorectal cancer screening programs, but these are not population-based. And what we mean with population-based is that there is no active outreach to the population at certain points in time. And we hear from previous speakers how important it is to ensure equity in programs. And I think not having population-based programs really is a big drawback for achieving equity with your programs. So in 2007, there was quite a bleak picture, and it was very clear that we really needed guidance on implementation of colorectal cancer screening in Europe. And I think in response to this, but also because, of course, you need guidelines in any case, in 2010, the first edition of the European Guidelines for Quality Assurance in Colorectal Cancer Screening was launched. And the aim of these guidelines was to provide guidance on effective and efficient implementation of the EU Council recommendation of colorectal cancer screening. And again, two important aspects were mentioned in these guidelines: that to achieve the potential benefit of colorectal cancer screening, quality must be optimal at each step of the process. And because screening is predominantly performed on healthy people, it's very important to have comprehensive quality assurance so that you maintain an appropriate balance between the benefit and the harms in the large number of people that are eligible for the screening program. So did this launch of these guidelines actually lead to the wanted result? Well, in 2016, there was a new status update of cancer screening in Europe. And this picture is taken from that 2016 report. Well, the first thing you notice is that there's a lot more colors in this graph and a lot fewer gray countries, which means that there's definitely more progress being made. The second thing that you immediately see is that there's much fewer countries that are red. So much more countries switched from non-population-based screening to population-based screening. And actually only was 3 countries that still had non-population-based programs, of which one was considering moving towards or planning towards population-based programs. So yes, on the first sight, you would say that there is indeed an important improvement, maybe thanks to the European recommendations. But if we dive a little bit deeper into what the recommendations were, then you see that one of the key recommendations in the guidelines was that, apologies, in order to maximize the impact of the intervention and ensure that high coverage and equity of the program, only organized screening programs should be implemented. And if we look at what the definition of an organized screening program is, that actually entails 5 aspects. The first one is that there should be an explicit policy for the age range, for the test type, and for the interval of screening. The second one is that there should be a defined target population that is actively invited. The third one is that there is a management team that's responsible for implementation of the program. The fourth one is that there's a quality assurance structure that ensures that all aspects of the program have good quality. And the fifth one is that there's a method for identifying cancer occurrence and death in the population. All of these 5 aspects make up what is called an organized screening program. But what we've been focusing on so far in reporting is population-based screening. And what you see here is that population-based screening actually entails only the first 2 aspects of a truly organized screening program. So we're leaving out an important aspect. And I would like to argue that with quality assurance structure, you have all 5 covered, because you can only have a quality assurance structure if you know who your target population is, if you invite them actively so that you can follow them up, if you have a management team, because that has to be responsible for the quality assurance structure. And of course, you can only do quality assurance if you can measure the outcomes. So quality assurance, in my opinion, is sort of the pivotal wheel of what an organized screening program entails. But if we then look at what we know about the colorectal cancer screening programs in Europe, this is again from the same 2016 report. You see that there actually is, with respect to examination coverage, to a certain extent, still reasonable information. However, if we go deeper into what information countries have about their screening programs, for example, with respect to screening participation, you already see that there is much more grayish form and very few colors actually in these programs. So meaning that this information was not available at the time that the report was made. And the picture becomes even more bleak if you look at more detailed outcomes, such as advanced adenoma detection rates. So basically what we're doing here is we're threading in the dark. We don't know how well our programs are performing. And if you don't know how well your program is performing, how can you even improve? I've had the pleasure to be part of the Utopia project, but also of a project together with IARC from DG Reform. And from that, I've met many representatives of colorectal cancer screening programs across Europe. And there's a few aspects of the colorectal cancer screening programs that I see popping up in many occasions. If you look at the most important one, as I said, most programs that I encounter are population-based because invitations are being sent. But there actually is a lack of a governance structure for screening. No one is responsible to monitor and evaluate what happens after sending that invitation. Often reminders are not even sent because we do not simply know who has responded, or we can find out, but it's so much trouble that we're not doing it every day. Also, what you see is that there's often not one data infrastructure for the screening programs, but they are using fragmented and often outdated existing data infrastructure that are not linked to each other. And because of that, we cannot monitor and evaluate the programs, and thus we cannot do quality assurance. In many countries, cancer registries lag behind. And because of this lag and incomplete data, we also don't know what the impact is of screening programs on the eventual outcome, colorectal cancer incidence and mortality. And then finally, what has really been hampering many programs, including the Netherlands, is the interpretation of the GDPR. This differs from country to country. In the Netherlands, we're not allowed to receive phone numbers from the individuals because we do not strictly need them for the program. And so we can only send out mailed invitations. In other countries, actually, people only have the telephone number because they're not allowed to have the address, or they are allowed to have the address, but not the names of individuals. These all hamper a good quality assured program. And I think we should really sit together with the countries and representatives from the countries to see what the right or wrong interpretation of the GDPR is. And then finally, I think I've seen in many countries that there's a lack of funding to implement that requirement, governance, and IT infrastructure. So the key take-home messages for me from this presentation is that, yes, there has been a considerable expansion of colorectal cancer screening programs since the publication of the EU Quality Assurance Guidelines in 2010, which is of course good news. And also the good news is that thanks to the emphasis in the colorectal cancer screening report, the large majority of these screening programs is now population-based, and so actively outreaching to the population. However, if you closely read the recommendations and the guidelines, population-based alone is not sufficient. Quality assurance structure is essential for effective programs. And that's why we maybe have to look carefully at the EU recommendations or the guidelines in 2010 and look in the new ones. Maybe they are too comprehensive. Maybe we can prioritize the guidelines, because every country that I speak to knows these guidelines and they consider it the way to do a good colorectal cancer screening program. But I can also imagine that the perfect becomes the enemy of the good. They see a huge mountain they have to climb because there's so many things you have to do that maybe they give up before even starting. And maybe we can prioritize some of the guidelines to make sure that at least you should reach that level. And then finally, I would say that the nice pictures that I presented, I think it would be really good if we also have pictures like that that really show if it's an organization-based programs, because that would really show that we still have a long way to go, and it might also drive countries to actually take that extra step. So with that, I want to thank you for your attention, and I'm happy to give the floor back to Tamsin.
Thank you very much. It's very detailed and very useful to understand both the areas where we've got progress, and you also highlighted areas of concern where there's still quite a lot of work for us to do in order to make the best use of what infrastructure and facilities are in place. And now we're going to introduce a panel of speakers who are going to comment and respond to that presentation by Professor Lansdorff-Vogelaar. So joining me, I have Kieran Nicol, who's the head of unit Health and Society at the Joint Research Centre for the European Commission. I have Titi Sarkiala, the director of screening for the Finnish Cancer Registry from Finland, and Christian von Wagner, the Senior Lecturer in Behavioral Research in Early Diagnosis of Cancer at the Health Behaviour Research Centre for the Department of Epidemiology and Public Health at UCL in the UK. So welcome to all of you for joining me. I'm first going to give the floor to each of you just for a few minutes to make a comment and a statement based on what you've just heard from Iris. So Kieran, can I offer you the floor first?
You're
on mute,
Kieran.
That's it. Nope, I'm still not hearing you. I apologize, we still can't hear you, and yet I don't see a mute sign on the screen.
I'm changing microphone.
That's
Does
it.
that work? Okay.
Yes, go ahead.
The other microphones somehow must have disconnected. Good morning, everybody. Sorry for the technical glitch. Thank you, Tamsin. And first of all, I want to commend Digestive Cancers Europe for the great work they are doing. Yeah, my name is Kieran Nicol, and I'm working in the European Commission's Knowledge Centre on Cancer, and thank you for this kind invitation. Now I have 4 minutes, so I will be quite brief. I do believe Natasha will show some slides, so if they pop up, that would be great. If not, I will proceed in any case without. So let's get going. Thank you, Iris, for the fantastic introduction about population-based screening programs. What I will talk about is just in 1 minute, I will explain what we're doing in the European Commission in the context of the Knowledge Centre on Cancer. And then I will go into the details about what we're doing on colorectal cancer specifically, European guidelines and quality assurance schemes. So the first slide you see now in front of you, and thank you, Natasha, is an overview of the pillars of the Knowledge Centre on Cancer. In the last 8 years, the Commission has started building up activities on cancer. This is very strategic in terms of coordinating, not reinventing the wheel, having a central point that is independent of all commercial, private, and national interests, that is evidence-based, and that puts the patient/citizen first, regardless what country they're in or what region and what country. Now, on the top left-hand side of your screen, you will see the European Cancer Information System. That was already mentioned, registries. This is based on information from 150 cancer registries. It is used for projecting and for monitoring the burden of cancer in Europe. It is expanding as we speak. This is growing. It has over 60 million cases covering 64 cancer sites. Of course, priority goes to the top 6 cancer sites as recognized in the Council Recommendation 2003 and now updated in September 2022. So this system will be including, in the future, we're looking how to incorporate the monitoring of population-based screening programs. This is really important. Without monitoring, showing impact, if you want to get the uptake, that is the way to do it. Show that it works using evidence and using data. On the bottom left-hand side of the screen, you will see the latest kid on the block. It was launched.
Sorry, I think we seem to have lost the connection, or he's frozen. Perhaps if we wait to see if we can try and fix the connection, maybe I could invite Titi to take over and to give your intervention. You're on mute. That's it.
One mute person again. Well, okay, nice to be here today. I'm Tytti Sarkeala. I am a director of screening at the Finnish Cancer Registry, and I was asked to tell a few words about our new fit-based colorectal cancer screening program in Finland, that what have changed and challenges for the future. And I have 1 or 2 sentences for both of these. As you may remember, in Finland, we have had a pilot phase in 2019 to 2021 in 9 municipalities of fit screening for men and women aged 60 to 66 with various cutoffs. And based on the first year results, we have also published a paper about the study design and also published a cost effectiveness analysis based on MISCAN modeling together with Erasmus University and IRIS. Thank you again. And based on these results of this cost effectiveness analysis, we planned a national screening program for men and women aged 56 to 74 in 2 years interval. And this has been launched now from the beginning of this year. And well, after we also launched a National Screening Act, and based on this, we were able to start the national program in January. And thereafter, we have also produced screening protocol based on European recommendations, and we have also launched a list of accepted fit tests based on validity research in European screening programs. And now we are in a situation where this program has just started, and we have incorporated 4 new screening laboratories into the program, and we have also built up the IT systems and etc. etc. So we have been very busy during the last two years with this program. And what are our challenges for the future? Well, mainly we are preparing a national quality manual now within an expert group for the program, and that should be ready by the next summer. And then we are also we are very much processing to keep up the excellent participation rates, which we achieved in the pilot phase. That was 80%, and we are a bit behind at the moment, like 75, but still in a good process in that. And we also want to ensure the feasibility of the overall performance throughout the screening chain, from the invitations to treatment. And we have noticed, unfortunately, that currently we have some delays for example, between the posting of positive test results and the time of colonoscopies. And it seems that we have some shortage of personnel and devices, but we have to check it up more carefully. And we have sent letters already to the screening units to find out that what's the problem there. And then, of course, we want also to ensure that the screening performs as well as possible for both genders, meaning that the positivity rate, the follow-up rates and the detection rates are okay, and the positive predictive values of test and colonoscopy also are still at the suitable level. And if not, then we need to do some modifications. And of course, now in the pilot phase, we had only 1 test for gold, but now we have accepted 2 tests in the program for gold and OC sensor. And now we are following whether these tests are working accordingly or in the similar way. We have 25 micrograms per gram fit cutoff for both genders at the moment, and we are following whether this is working or not and how these tests are working. So this is currently the situation in Finland.
Thank you very much for sharing the perspective and the recent developments. And also interesting that you are following up by directly contacting the centres to find out what's happening, why we've got that loss to follow up. So that's interesting. Kieran, I think we've got you back, and apologies, we seem to have lost you halfway through what you wanted to say. Would you like to pick up, hopefully, where you left off? We really are not having very much luck with Kieran's connection today. You're on mute if you were hoping to be talking. Apologies, maybe we'll move on to Professor Christian van Wagner before we try and get back to Kieran. who's, I think, connecting with us from a commission building. We're really not having much success. Christian, can I turn the floor to you to respond? And I think you're going to particularly highlight some of the things that were spoken about by previous speakers, which is the inequalities, the socioeconomic inequalities, and how we address them.
Yes, thank you. Thank you so much for inviting me. I am a reader at University College London, so you've slightly over-promoted me in my title. I'm still Dr. Christian von Wagner, but I have had indeed a lot of experience in trying to address issues around uptake and inequalities. So I'm going to talk a little bit about both of these things. Firstly, really to just highlight again and maybe re-emphasize the issues that have already been brought up by various speakers, including Iris, around uptake and inequalities. So I think one thing that I want to highlight here again, and I just looked at a paper that's only a few years old from a group in Germany that tried to look at uptake across sort of Europe and other constituents. And one of the key messages there was, again, organization, and the fact that the variation that we see in uptake, the first root cause of much of that when you compare countries is how organized they are, whether they routinely invite people, and also, of course, the test they use. So I think it's really important to have a consensus around the approach that people use. And I think there is an emerging trend to that using a triage test such as the fecal immunochemical test that's known to be reasonably accessible to many people, but doing so in an organized fashion with routine invitations is really important. I think one feature that I want to highlight there as well is to make sure people are never left behind. So one of the first things that I learned in monitoring uptake was the importance of repeat invitations. So this is not just monitoring non-response within a screening round and sending out reminders. We'll say a little bit about that, but also really the importance of going back to people, even if they haven't responded to their initial invitation. You gain far more than you lose. Most people, if they take part, have taken part before, will do so again. But crucially, even people who haven't taken part on the first or even second or third round, a lot of them will come back, and that there are a lot of reasons for that. They see other people take part, they might be inspired or prompted by relatives or friends who have just joined the program. So never give up is one really important message there. Also, we should not forget that, particularly if you're using a triage test such as FIT, in the first instance, that diagnostic follow-up is an important feature. And yesterday, when I just glanced over some of the literature around uptake again, I saw a lot of initiatives to better understand follow-through or uptake of a diagnostic colonoscopy. And I think that's particularly important as we are making important gains to uptake of the first test. One of the potential, not drawbacks, but things that you have to be aware of is that if you open the program up to a wider set of constituents, you might need to work harder to then also make sure that they stick with you and continue to take part in follow-up tests. Because in England, we found, for example, a really positive trend when we changed from the guaiac test to fecal immunochemical test. Not only did that substantively increase uptake overall, but what was really encouraging is that it increased uptake even more so in those lesser herd groups, or the groups that we know are less likely to take part. That's previous non-responders, that's men, that's people from socioeconomically disadvantaged areas. We should also not forget that these are some important characteristics, but other important groups that present that have specific needs and should be included are other marginalized groups, people with mental, cognitive, or physical disabilities. Very important that programs learn to better monitor and be able to target those populations and give them additional help. Because even with FIT, there might be some important barriers there. So that's what I want to say about uptake. Just briefly about interventions. As I said, key is effective organization. Beyond that, it's also important to keep monitoring the content to make sure that you base your information on good research, on theory and evidence-based materials, that you base your understanding of the content on behavior change models, for example. Also to use technology. We know that text messaging within a screening round, phone-based reminders can have an important impact, but also to integrate stakeholders. We know that, for example, general practitioners have a very important role to play, but we should also expand that to maybe community pharmacists and to people working in social care, for example. There's a lot of enthusiasm around personalization, and this should also be applied to health education. And I think I'll leave it there, and maybe we can take it up in the discussion.
Fantastic. Thank you so much again and I get this message very clearly. It's about organization. If you have the organization that overlays the structure, then that allows you to make full use of it. Kieran, let's see if we can try one more time. Apologies that the technology is not serving us well today.
I am so sorry, Tamsin. Can you hear me?
Yes, we can.
This is embarrassing. I mean, I got kicked out twice, but anyway, okay, enough about the technical glitches. Let's continue. Yeah, I was giving the overview of the Knowledge Centre on Cancer. My apologies to all the participants as well. Sorry for that. Basically, they are the pillars of the Knowledge Centre on Cancer, which is commission-based, which its mission is to foster alignment and coordination of all activities on cancer at the European Union level. And this is really important to leverage impact, and it's all about impact. Next slide, please, Natasha. I won't go into more details there. Basically, for the colorectal cancer work, we have started working on the new European guidelines and quality assurance scheme for colorectal cancer screening, diagnosis, and care. We call it the European Commission Initiative on Colorectal Cancer. So the aim there is to improve the quality of prevention, screening and care, and contribute to reducing the inequalities which we've heard about in accessing cancer services across Europe. Now, very important components of this scheme is that they are evidence-based guidelines. That was mentioned also by the parliamentarians and also by yours. The recommendations for prevention, screening and diagnosis are independent of private, commercial and national interests, and we are tailoring these for the member states. That's where the quality assurance scheme comes in. The quality assurance scheme converts the recommendations to quality indicators under the umbrella of a scheme that is tailored for the member states, for them to implement these guidelines. Also, these guidelines will be updated in real time as soon as new evidence becomes available and goes through the systematic, very stringent review process, making sure they are tailored for the member states. Now, here we're talking about essential standards. Applying essential standards, not the most innovative method, etc., etc. So the targets are, of course, the European Union, but it goes beyond the European Union. We have a multidisciplinary working group of 15 members. We talked about the evidence-based recommendations and the quality indicators, really important. And by the way, we've learned from the breast cancer work, we have a new methodological approach, which is published internationally, guidelines, international network, you name it, about how to do this, develop quality recommendations and indicators in tandem together, using the experts together. Before we had two separate groups, guidelines, quality assurance, now we have them together. Next slide, please, Natasha. So basically moving on, in a very brief overview, this is the roadmap. Where we are. We're in the preparation phase, the meetings have kicked off, training is ongoing at the moment. Mapping and selecting the healthcare questions is ongoing and identifying the existing requirements and indicators. Subgroups have been set up. I will give a little summary later on. And the news is that by 2025, which is not that far away because already 2023 is knocking on the door, this will be delivered. Next slide, please, Natasha. So the status really is the 4 subgroups already have been set up and are working on different outputs. 50 healthcare questions on primary prevention and screening have been prioritized to be included in the guidelines. Stakeholder consultations basically will be published at the end of this year. So on the prioritization of the healthcare questions. The certification work will be finished by the end of January next year. And then the first set of recommendations on prevention screening will be finalized before next summer. So basically the last point is the one I want to bring your attention to, because I'm very acutely aware that we have top level experts, professionals attending this wonderful summit. So see the last bullet point, 60 experts are being included in the, let's say, the Commission's expert group. And there is an open call still going on for experts, and it's available on our website. Now, basically, you will receive this link afterwards, but we encourage and invite all experts to apply or to be part of this, time permitting, of course, because yeah, the more expertise we have on board, the better. So going back very briefly to address some of Iris's points about evidence-based guidelines and the quality assurance schemes. Basically, the quality assurance scheme will be the key to implementation in the member states. Right now, as you know, we finished the breast cancer work last year. We are testing it in 21 breast cancer settings in 10 countries. And so far, the results look very promising. We want to go the full mile this time. We just don't want to produce probably the best guidelines in the world and say, there you go, and walk away. Not good enough. We need to implement, we need to monitor, we need to close the loop, come back and going, yes, we've implemented these guidelines. They do have an impact. This is where we improve. And then we start raising the bar throughout the European Union and beyond. This is the essential part. The European Cancer Information System will help. And now we have the European Cancer Inequalities Registry. The 6 cancer sites of the Council recommendation, and it was Iris that mentioned it, or no, one of the MEPs, that they constitute over 50% of the burden of cancer in Europe. So by addressing these 6 cancer sites, and now we're on colorectal cancer, that is the key to turning the tide against this formidable disease. So basically, in a nutshell, that's where we are. Back to you, Tamsin, and I'm sorry again, everybody, for the technical glitch.
No worries, Kieran. I'm glad we had a chance to hear from you, and that welcome call for experts that people can still join and be part of the conversation, and the logic of why the 6 different sites were chosen is again very helpful to understand. And it's also a welcome to say that it's not enough to just issue guidelines. The Commission is interested in actually the implementation and is going to monitor it and highlight where we're making changes. So thank you. And this is an opportunity now for the audience to share your questions in the chat. I have a couple of questions as well, also to our panelists. The first one I think I want to ask you is that Iris has said we really now need to be looking at quality assurance in existing programs because they're not delivering yet. And before we would move forward, we really need to focus on that. So can I ask first your views? Is quality assurance the priority we should be focusing on? Titi, can I invite you to respond on that first?
Well, it certainly is. It's the key for all the organization and for the program, and that everything is needed. What Iris already mentioned, that you need to know your target population, you need to invite it all, you need to follow the whole screening chain, you have the IT systems ready, and you have to have national guidelines and to follow up, and you have to get the data to be able to monitor and report also. So nothing happens if you don't you can't be assured that you know what is happening there from the start to the end, and you follow it, and you have clear frames for indicators throughout the screening chain.
Okay, thank you. Christian, we've got something I think that's come in the chat that is it falls clearly in your area of expertise, and so we've had a question, actually it's a comment that says the homeless, that's a weak link in the program, partly because we have to rely on people to perform the test effectively. So again, I think this is looking at an underserved population that might be at risk. And also we've got another question that's come forward saying, you know, the importance of involving stakeholders. We talked about GPs, pharmacists and health workers, but how do we broaden that to involve members of the public? Because Dr. Albawi talked about stigma and taboo, and surely there's an area where we can involve peer educators, community groups, faith leaders and others to try and address some of that. So Christian, can I ask you to come in on those?
Yeah, definitely. In terms of the first thing, and I think this goes back to quality assurance as well, is know your constituents. And I think we still don't know enough about them, because there are still some structural barriers in terms of homelessness. Absolutely, in our country, for example, in the English program, if you're not registered with your GP, you're essentially invisible to the program, and that is a real problem. And it, you know, some of these populations are, and some of these issues are being addressed by the program. So I know that there's a lot of work with some of those groups, including also people in prisons, and how to kind of make sure that they are being reached if they're eligible for screening. And a lot of that relies on community. And that brings me to the second point, really important. Before I agree on involving members of the public, which absolutely is the case, we should not take for granted that the healthcare workers are actually integrated, because they're not. Not even GPs are actually adequately integrated. They are sometimes integrated, they're sometimes used maybe the practice names are written at the top of letters, but at the beginning of the program, there was actually very little that done in bowel cancer screening, and other screening programs have done far more to integrate, even GPs. Community pharmacists, there's no integration. This is just an aspirational statement from me. They should be integrated. So there's a lot to be done. I think we're doing actually more with members of the public and community group. There are a lot of examples at a local level, at least. And I think that it works best if it is actually a pathway that connects health and the community. So one example is a wonderful local initiative where people are invited, or non-responders are invited to attend their GP, but when they're at the GP, speak to not their GP, but a member of their community, who has been trained, who is a health improvement officer, but is very close to them in terms of the demographic match. They can speak to them in their own language, and they can address issues like taboo. And this has been shown to work, and I think that's absolutely true. But we must really also start to really systematically integrate other healthcare professions as well.
Thank you very much for that. And thank you, Kieran. I see you've put in the chat the fact sheet from the European Commission so that people can download and look at it. Iris, can I come back to you, because you've had a couple of questions that I think are relevant for you. And I know you wanted to add in on this bit of involving the public, but we've got a question, I think it's a clarification, because you mentioned that in many cases it's not possible to know and track who doesn't respond to the screening invitation. Has the audience person said, did I understand that correctly? Because if you know who's invited and you know who responded because you give the fit tests individually, how is it possible for people to fall in between? Because surely you know, if from A to B, something's happened. So maybe it's just that it wasn't very clear in the way you described it. So perhaps you could add to that.
Yes, well, there is actually countries where indeed there is sent an invitation for fit screening, but the fit is not included. That needs to be collected at the GP. The GP sends it to the lab, and the lab reports to the person and to the GP, but that report doesn't come back to where the original invitation was sent from. And there might be ways to access the information from the labs, you would say, because there might be links between the lab and the patient number that you could, but that's not standardly done. So there's many countries, what I was talking about, that have fragmented IT systems. So the invitations are recorded in one system, the results are recorded in another system, and there's no link between those. And it's oftentimes very hard to link them because they are outdated and old. And so building interfaces is not an easy thing to do.
Thank you. So it comes down to the organization and the fact that it's all fragmented. Thank you for that. And Arlene's commented that, yes, if you take Belgium, we've got 3 regions, 3 different systems. And I think during COVID, we had the strange spectacle of 9 ministers with some responsibility for health all having a role. So that's part of it. Kieran, can I perhaps invite you to respond on the issue of GDPR? That's an EU level piece of legislation, but it is adapted and interpreted quite differently in different countries. And it's been mentioned by a couple of our speakers as being a challenge to being able to follow up and proactively engage with people. What's the view from the Commission?
Well, thank you, Tamsin, for that easy question. Yeah, the GDPR, General Data Protection Regulation, I'm working with the Commission, so I, of course, support it, but it has posed many, many challenges. And I do believe there are many groups now, feeding back into the system, saying how it has, let's say, put many challenges against progression when it comes to healthcare, when it comes to screening, because if you're going in the direction of personalized medicine, privacy, of course, is a fundamental aspect. So while it is, even from our own part, in the Knowledge Centre on Cancer with the European Cancer Information System, or the guidelines, and now on inequalities, where we're including LGBT+, homeless, etc., the privacy issue is constantly a challenge, and GDPR conformance is. Now, as yours nicely, in a way, nailed it down a little bit, the interpretation of the GDPR is an issue where we do believe it should be looked at in a very, let's say, holistic, targeted way. Different interpretation means different layers, means lack of communication across the borders, etc., etc. But this is an aspect that we fully support. It should be looked at, and we've been doing that together with the cancer registries, where we've managed to reach a common ground with regard to registration through a contractual arrangement, basically. Whereas we've seen, because in that scenario of the European network of cancer registries, we've seen the diversity in interpretation from Nordic countries, which tend to be quite strict on it, southern less, eastern, western, etc. It doesn't matter which way they do it, but there are differences in interpretation. And this is also adding more layers of complication to its implementation. Now, I do believe that feedback mechanisms, I know, are in progress, going back to the Commission, by the Parliament, etc., highlighting these issues. We do not want to curtail or to hold back progress in health in Europe. We're talking about a future European Health Union. Health has to be a priority. What better gifts could you give to your citizens and to patients? So I do believe we will see progress in that in the coming years. I have nothing concrete to say. I'm not working directly on it. We would need to contact the lawyers of DG Santé and the various in DG Just, etc., etc. But I do know that there are, let's say, vibrations and rumors going on that things are happening where these issues are being highlighted. And I do hope it will all be taken on board and will lead to, let's say, a smoother implementation. Let's put it like that. Back to you, Tamsin. Thank you.
Thank you very much, Kieran. And we're now heading towards the break. So I just want to wrap up this panel to say thank you to all of our panelists for sharing your expertise. And we've had this challenge put to us by Iris to say, what, we should, if we focused on the quality assurance of what we've got in place, then we would get better outcomes. We had the message from Christian that, there are ways of reaching the hard to reach communities, to never give up, keep going, keep trying. And we heard recent developments from Finland to see how you can take this and ensure that we have greater uptake. So there's lots of potential for us to explore how we can use things better. But a reminder that sometimes it's as simple as putting attention to make sure that IT systems talk to each other, investing in the idea that we want that follow through, that implementation. So thank you to all of you in the panel. We're now going to invite you to take a 10-minute break. Get up, get yourself a cup of coffee, move around. This is your public health moment. And we will start again at 10:25 with the next panel, which is going to look at new strategies for data collection and analysis. Thank you and see you in 10 minutes.
Thank you.
vetäjät ja siellä on ihan kiinnostava keskustelu. Paneelissa piti tuossa äsken niin kuin 4 minuutissa selittää, että missä ollaan nyt tässä Suomen suojeluseurannassa ja mitkä on niin tulevaisuuden tavoitteet ja haasteet. Vaikeaa teillä on tuommoista tämmöistä. Ja sitten Iiris selittää, että on tärkeää, että kerätään dataa ja on tärkeää, että on quality assurance. Sitten kun kysytään, että mitä se on tuosta. Tärkeää quality. Totta kai. Siis täällä siinä. Kyllä se Iiris jaksaa. Kyllä se jaksaa pitää asioita yllä. Se oli nyt taas tosi hyvä esitys. Niin kuin semmoinen. Mutta kun tuntuu, että itse jauhaan niistä samoista asioista aina, koko ajan, jatkuvasti. Ja ne tuntuu olevan aina koko ajan ja jatkuvasti tuolla olevia juttuja joka suunnassa, niin vähän niin kuin turhautuneeksi tässä siitä tulee. Mitä hittoa. Tämä jatkuu siis. Ja pari session verran, tuon seuraavan vielä ajattelin katsoa, että se menee varmaan jo 12. Mutta voit lähes syömään vaan sitten, jos tulee, niin se jatkuu 25 yli ja mä en oikein tiedä, kun se on vielä sellainen, mutta sitten viimeinen sessio on semmoinen, jossa ne rupeaa pohtimaan sitä, että pitäisikö alle 50 se. Niin sitä mä en kyllä ajatellut suunnitella enää, että se jää näin semmoista sussua, jaksa kuunnella, mutta tuon seuraavaksi jää.
Hello, everybody. Welcome back. I hope you had a chance to get to move around, have some coffee and refresh yourself. As I said before, we're now going to address in panel 2, we're going to look at issues around new strategies for data collection and analysis in CRC screening programs. Now, we heard in the previous panel, sometimes the challenge is that the data does not flow as it should. If you don't have the data, you don't know who's falling through the gaps, and you don't know what else you need to do to improve your services. So we're going to start by having a presentation to explore how we're going to take this forward. And then we're going to be, again, having our panel conversation. So I would like to invite Professor Carlo Sinori to share with us, his expertise and view on how we collect the data and how we analyze it. Professor Carlos, the floor is yours.
Thank you, Tamsin. I have some problem probably with my camera. I try to anyway to share the screen. May I?
You should be able to share the screen if you've got a problem. I'm sure we're able to put the slides up for you.
Okay, that should be okay. Just a moment. Can you see the screen?
I can see the screen. It just needs to be in presentation mode. That's it. Excellent.
Excellent. Okay.
There you
go. Here is the.
While we're waiting for your screen to work, it is. And Professor, please allow me to introduce you. You're from the Piedmont Region Cancer Prevention Center for the University Hospital Città della Salute e della Scienza from Italy. Please excuse if I haven't pronounced the Italian correctly, but you're very welcome. Please, the floor is yours.
Thank you very much. It's thank you very much. Perfect. Also the pronunciation. Can you see the screen now?
Yes, we can. It says no conflict of interest to disclose, so we see the screen.
Okay. So thank you. The systematic monitoring is a key characteristic of organized program, as it supports efforts aimed to optimize the quality, and we have already discussed in the previous panel about the importance of quality at each phase of the screening process, which represent a necessary step to achieve the expected reduction of disease-specific mortality in the target population and to achieve a favorable benefit to harm ratio. We want to evaluate the entire screening process, a process which involves several different phases, steps within each screening round, and which is repeated over several rounds often. So the idea of having a longitudinal prospective approach seems more appropriate for these for the purpose of this evaluation. Quality assurance. Well, monitoring is supporting quality assurance as it provides information to perform regular audit of program activities, to provide appropriate feedback to the staff, and to identify retraining needs. It also provides data information to support explicit and transparent communication of uncertainties of the rationale of the policies adopted, which can favor informed participation in the screening program. And also its availability of appropriate and valid comparison across cancer screening programs are essential for policy and decision makers to evaluate and to improve their programs. And we have monitoring tool have been developed to make available comparable results on key quality indicators of screening performance to data providers, policymakers, and other stakeholders. And they can also be used as self-assessment tools for screening programs, allowing to compare results with guideline standards and benchmark, being able to apply the appropriate selection and stratifications. And one of these tools is has been developed within the Utopia project, an Horizon 2020 program, funded within the Horizon 2020 program and coordinated by the Erasmus Medical Center in Rotterdam. And based on this monitoring tool, which has been developed as a part of the quality cycle, we can identify areas of poor performance. And based on the various analysis, we can model different scenarios to simulate the future impact of choices to address these problems, these critical situation in the programs, and to build roadmaps involving the relevant stakeholders, and to implement these roadmaps, and then monitoring the impact of the roadmap implementation. We have other tools. This one, the CAN-SCREEN 5, has been developed by IARC based on the experience of second European screening report. And the CAN-SCREEN 5 is aimed to collect and disseminate information about screening activity, to harmonize data collection across different jurisdictions and different programs, and also to assist countries in implementing and improving their information system and their monitoring systems. The recently published proposal for the new recommendation of the European Commission on cancer screening is also recommending to establish the data system at the national level based on nationwide standardized data collection of all phases of the screening process, from the invitation to assessment, follow-up, and treatment. They are also recommending to have screening data linked and interoperable with cancer and mortality registries. And they are also mentioning that we can use the data as a secondary use for and the resource for cancer research and technological advancement in cancer care. And in the context of the EU4Health program, a new project has been recently funded, the CAN-SCREEN ESIS, which is coordinated by the International Agency for Cancer Research in collaboration with ECL, European Cancer League. And it's supposed to develop a portal which will be part of the European Cancer Information System, which is now including data from the Population Cancer Registry. This new portal will also include data on cancer screening activity. And the main goal of the initiative are to empower the program to evaluate their own performance on a continuous basis and to improve quality of cancer screening programs based on the benchmarking and evaluation and comparison of performance of different programs. But there are also limitations of current approaches. They are mainly based on aggregated cross-sectional data, usually presenting data for a single year of activity. And also the comparison of outcomes across programs using different protocols is often not reliable. Outcomes are not comparable without considering commensurable intervals. Appropriate interval for comparing colonoscopy versus FIT, for example, might be 10 years over a single round. The comparison is really valid or informative. Also, the screen history of eligible population may not follow the protocols. Individuals may not strictly respect the established screening schedule, and the different screening tests may coexist. So a longitudinal approach using individual level data seems preferable when comparing programs, and can also provide probably more valid and meaningful results. We have already some examples of the importance of using a longitudinal approach in screening evaluation, in evaluating the impact of the patterns of participation on the screening outcomes. We already documented that the positivity rate was twice as high and the advanced neoplasia yield was 3 times higher in the fourth round, for example, among subjects who never participated in 3 previous invitations as compared to those who had participated in all previous invitations. Similarly, when using the information about the quantitative level of hemoglobin measured among people with a FIT negative test, we observed that the advanced neoplasia yield over the following screening round was 20 times higher among screenees with a cumulative fecal hemoglobin level in the previous 2 negative FIT exams, which was higher than the positivity cutoff, as compared to those with undetectable fecal hemoglobin. So we can, using this approach, for example, we can identify subgroups of people have different risk of disease, and so we can eventually think to implement risk-based, risk-tailored approach. And this will be crucial in the future because a risk-based approach will be part of the scenario in the near future. The revised version of the cancer screening recommendation from the EU Council is including the indication to implement risk-tailored screening within population-based program whenever appropriate. So the having longitudinal data would be important to support these, the implementation of this recommendation. And in fact, the colorectal cancer screening interest group of the International Cancer Screening Network has recently proposed the implementation of a consortium to set up a common individual level database of screening history from different cancer screening programs across the world to be used for joint research and also for comparative analysis of benchmarking. Participation, all consortium members can participate in the definition of the research objectives. And one of the added value of this consortium would be training on how to refine data monitoring program organization in the different jurisdictions. Based on this proposal, there is now a cost action proposal submitted. We hope it will be successful. Again, initiated by the International Cancer Screening Network, the Colorectal Cancer Screening Interest Group. And the idea is to establish an international multidisciplinary consortium of colorectal cancer screening programs aimed to implement a common accessible database. We have now 19 European countries, 1 international partner, Canada, and also IARC and Digestive Cancer Europe are participating in this initiative. The aims are to harmonize data from different programs, to define a computational approach to extract the relevant indicators accounting for difference between programs, addressing ethical and legal related aspects related to data sharing in the context of international initiative. And of course, GDPR would be one of the topics, hot topics in the evaluation of this aspect. And maintaining a sustainable and collaborative network that ensure optimal exchange of knowledge and to keep colorectal cancer screening up to date. And this is the aims. These are the aims of this cost action proposal just submitted. In conclusion, the continuous monitoring and reporting is required to assess the impact of screening programs on population health. The evaluation of measure of quality and equity to implement cancer screening are dependent critically on collection, computation, and dissemination of accurate and comparable data to measure performance and outcome indicators across the screening pathway. Data collection should be part of the screening process, progress from aggregated to individual level data, include screening and clinical data. And citizen and patients should be included in this process, as ultimately sharing data may contribute to protect their health. Thank you very much for your attention. Thank you to the Colorectal Cancer Screening Interest Group for the ICSN, and particularly to Professor Senyan, who started this initiative with the consortium. Thank you very much.
Thank you very much, Professor. That gives us some insight into some of the issues related to data collection, and particularly the link there you had at the end about how you make the link from the big aggregate picture and bring it back down to the individual, so that we have both more buy-in and more engagement by citizens, but so that you can also have direct positive impact. Now, I'm delighted to invite a distinguished panel to comment on what you've just presented. And let me introduce everyone. We have Professor Mircea Manuch, who leads implementation of the training programs for healthcare professionals in the first pilot projects in Romania on colorectal cancer. We have Professor Rema Kvamicava, a professor and head of oncology department in Tbilisi State Medical University in Georgia. We have André Cavallo, a senior scientist for early detection, prevention and infections at the AIRC in France, and Marianne Vitelloni, who's a medical and scientific project manager at Digestive Cancers Europe, based here in Belgium. So welcome to all of you. Let me start, I think, by inviting Mircea to share some perspectives, highlighting what's been happening in Romania, particularly the pilot screening, and because we're focusing on data in this session, can you tell us particularly about your strategy to develop the database?
Hello, everybody. First of all, I would like to say thank you for the invitation. Actually, it's supposed to be Dr. Carmen Ungurian, who will speak on behalf of our team from the National Institute of Public Health, but maybe everybody knows, maybe not. She had some personal problems, so she could not reach the invitation, and she excused herself. That's why I'm some sort of, let's say, surrogate for this presentation. I was not prepared to be here, but I am here. And so hello to everybody. First of all, I would like to say that was already mentioned that in 2016, when that report came out from the EU, Romania with Bulgaria and Slovakia was the black sheep of the European Union, since no program developed at that time on colorectal cancer screening. Therefore, we had to do something. And we imagined these activities. We started because, of course, the other problem was the funding. We started the pilot projects with EU funding from European Social Fund. After that, when we started projects, came COVID pandemic, so we have other problems. In order to overcome this situation, everybody knows that screening programs, even well-going screening projects, go wrong during that period. But at the end, we had to do 50,000 fit tests in 4 regions, therefore 200,000 fit tests until November next year. And what is the most important part of the project is the national register screening as the subject of today. And regarding the screening, I was a big fan of Carlo. So a group conducted by Carlo offered support through another EU project via SRSS services. So we developed this register. And we had the advantage of the experience from the other states. We decided to develop the application in such a way to cover all stages of the screening, from the invitation, the provision of the test, the return of the test, so laboratory data, and moreover, we developed on this informatic basis an endoscopic standardized report and the pathologic standardized report. Therefore, the screening register is able to provide almost all the quality indicators from the screening activities. So not only the return rate, the values of the quantitative feeds and the positivity, the participation in colonoscopy, but also all the quality indicators like adenoma detection rates, advanced adenoma detection rates, the quality of preparation, the presence and the quality of sedations, the presence of adverse event, and the system is developed that the adverse events could be reported within 1 month. And also the pathologic report with all the data. Therefore, we can provide on real time on the national register all those quality indicators. Of course, we had many challenges like the development, as I say, during the COVID period. Also, the big problem was the development with EU fundings, because the implementation and reporting of the activities has to comply not only with the screening methodology, but also to the ESF framework and the GDPRs with different rules. For example, yes, we could not provide data to the ESF monitoring structures. So we have to do some sort of anonymization code provided to the persons invited to the screening. So of course, we had also different stages of digitalizations and level of service providers. In Romania, without GDPR, no screening program is possible. Therefore, GDPRs are involved here, and we have to teach them to offer some courses regarding the use of this kind of informatic support. And as the future, we are thinking to ensuring the sustainability of this application and to improve it, and of course to link it to the register of colorectal cancer, which is not fully available at the national level at this moment in Romania. So thank you very much for this.
Thank you, Chair, for telling us, some of the steps you're going through in order to develop that pilot phase. And if we hope it's successful and it can be adopted and integrated into the national screening program. We're now going to move to Georgia and hear some of their experience, particularly in the National Electronic Cancer Data Collection System. Rema, can I invite you to take the floor?
So, hello, can you listen to me?
Yes, we can.
So, dear friends, first of all, I want to thank you for invitation. Our team in Georgia in such a wonderful meeting. I will try in a couple of words to explain you which kind of situation we have in Georgia in colorectal cancer screening. But from beginning, please allow me to explain you in general what about cancer. So we have a total number of new cancer cases. We have 11,000. And we have top 5 locations in females. It's breast, thyroid, colorectal, corpus luteum, and cervix luteum. In men, they are prostate cancer, lung cancer, colorectal cancer, larynx, and so. So for general information, 40% of all new cancer cases we have in first and second stage. And the other 60% we have in stage 3 and 4. 5-year survival rate was 56.3%. So the cancer screening program was established in Georgia in 2008. And it was established, first of all, as pilot project in Tbilisi, capital city of Georgia. And after that, the program was expanded to different regions of Georgia in 2011. For this time, we provide breast cancer screening, cervical cancer screening, colorectal cancer screening. Colorectal cancer screening we provide for age group from 50 to 70 in a male and female target group. At the same time, enrollment methods are self-enrolled and by referral from GPs. For this time, we provide opportunistic screening. We try to move to the population-based screening, and I want to ask all of you, mostly the Romanian group, Slovakian group, maybe somehow you can help us with methodology how to jump from this opportunistic screening to population-based screening. Our biggest problem in colorectal cancer screening is that the coverage of target age group is very low. It's less than 5%. It's terrible low, and it is the main reason why we want to move to the organized screening. What about colorectal cancer screening design? We provide IFOP. On beginning, it was FOP test. Now we provide IFOP test. After that, if it's positive, we provide colonoscopy, total colonoscopy. We don't provide sigmoidoscopy because we don't have sigmoidoscopes. We have colonoscopes and we provide colonoscopy. And if it's needed, we provide biopsy with histological examination. And the last 2 years, we pushed our government and they are agree with us. And now we provide colonoscopy by general anesthesia. Because in other cases, many people don't agree to have colonoscopy. What about data collection? We have cancer registry from 2015, and we have cancer screening registry. We have our cancer screening program is split in 2 parts. The one part is for Tbilisi, for capital, and it is managed from city municipality, and the other one is for regions, all Georgia except capital, and it is managed from NCDC program. At the same time, we have two databases for capital and for regions. And it's our one biggest problem that there is no very good linkage to exchange information between these two database programs. What's more, so I think that once again, we are really very active. We want to do our best to change this situation. What about incidents? We have anything around 500 new cancer colorectal cases in Georgia. And this number of colorectal cancer cases are increasing every year. It means that we are really very active to build our colorectal cancer screening program with the best model. And I think that it's very important for us. Once again, I want to ask you if you see some possibility to contact us with our colleagues in our neighborhood, I mean, European countries, to help us how to move very effectively from opportunistic screening to population-based screening. Thank you. If you have some questions, I'm ready to answer.
Thank you very much, Rema. It's interesting to hear some of the challenges, the rising number of cases and the low coverage, and this challenge that you have of moving from opportunistic to screening, and that with the screening programs that you have a similar problem that we heard in other countries, is the integration between different databases, and therefore in order to get an overall picture of what's happening. Let's now turn to Dr. Andre Cavallo, who's going to share us a little bit of information about the CANScreen 5 project and the challenges and achievements of their data analysis. The floor is yours.
Oh, thank you so much. And thank you for the organizers for inviting me to be here today. And welcome to everybody. I will talk a little bit about, the CANScreen 5 project that was put together, as Carlos Signori comment, right, on a way to harmonize data collection. But as we have been seeing for so many different countries present their programs, that this is a challenge, right? So I'm gonna tell what we achieved so far and what are the big challenges that we see and how we think about possible solutions for it. So as I commented, right, CANScreen 5 is a web platform to collect data around the globe. It did start, as commented by Carlos Signori, in a collaboration with CPO. At first, the first data to be uploaded was the second reports, kind of how can we take a 360-page report with 200 tables and make it more easily seen the data. So in a more interactive way, and that's how it starts. But we also wanted to move outside Europe as well as international agents. We would like to have data around the globe. So one can just imagine that trying to harmonize that data collection has a lot of challenges. Today, we have data from around 8 countries and we're expanding. So it's feasible. That's the first point. But the main issue is that because we want to harmonize, we don't want people to give us the key performance indicators. Rather, we want them to give the actual numbers, right? How many people you screen, how many of those were positive, how many of those got the colonoscopy, and what happened with the colonoscopy, and so on. And countries have different ways to calculate the performance indicators. So we need the numbers, and that's the first hurdle that we see, because a lot of countries do have the key performance indicators, but those are based in surveys. And when you ask, what is happening in your program, they will not know the numbers itself. As also comment, we need to try to move on for having individualized data to really understand what's happening with the cohort. But it is also common in her presentation, and have been talking to many others, that the GDPR, as is interpreted to many countries as of today, prevent even the country itself sometimes to have individualized data coming from different health systems, information system. And then one can just imagine if countries are struggling to share data in between the health system facilities, how can EU get all that individualized data before. So we definitely, as EU, should think about a legal framework on how it's feasible for us to have that kind of data, but still make sure that the GDPR rules are in place and have been followed. And talk about individualized data and KPIs. What we see mainly outside EU is that data from some programs are not even from the same cohort. Some countries tell us in this year we did that many tests for screening, in the same year that many FIT tests were positive, in the same year that many colonoscopy was performed, but we don't know if they're not talking about the same person, right? So because we know that someone that got screened in 29th of December going to have the FIT test result in January next year, and depending on the waiting list, colonoscopy can be later on, the diagnosis. So we begin to put together a lot of different cohorts, and that's really got a lot of bias in how we talk about the key performance indicators. As well as when we talk about data, as far as we go in the cancer screening pathway, less data is usually available. Programs really know how many people they screen, but then when you ask how many of those got colonoscopy, this is done in a different level. This is done in some secondary level clinics, and then they say we don't have information for all those health services. So, and how many got cancer? If they don't have a good populational-based cancer register, they don't know from that. So further we go, less idea of numbers and completion of the program we have. And this, when we're talking about countries, we keep thinking and talking about not only integration of the system, but a better system, because when you go for different levels, also endoscopy services begin to use different IT solutions to collect the data, and this gives yet a different layer of getting all the data together. So this lack of linkage of data that have been common so far also prevent us to have a better and complete overview of the screening programs. In a nutshell, harmonization and improve of data collection, including work on data linkage, while allowing for the GDPR rules to be followed, is what's going to granting us better data that we can measure the screening programs, monitoring and evaluation way better. We hope that we have the second EU report, a little bit old at this stage. We hope that soon a third report is going to start and we can see some improvement from the second, but it's still, I guess, going to be a lot of work for us to get an even better fourth report in the future, as we're still struggling with the data protection and linkages and data completeness. Thank you so much.
Thank you very much. I mean, wow, that was quite extraordinary to understand that we're actually generating large amounts of data. It's because we haven't got the data connected that we can't see the pattern. So we can't properly analyze it. We don't know what that data is telling us. So this is really interesting to try and understand it. We're now going to pick up on the issue of the GDPR, and this is designed to protect the privacy and the ethical frameworks for patients. So let's have a little explore now about how patients feel about this. So Mariana, let me invite you. What can you share about the perspective of patients? What's their opinion about data collection and sharing?
Thank you, Tamsin, for this question. So we discussed this topic and the new European health data space with our member organization during the last masterclass in Barcelona. That is the event DiCE organized every year to bring together its member organization during the ESMO GI in Barcelona. So for patients, sharing data can be a valuable tool for cancer research, as it can lead to better treatments, of course. Also, having a comprehensive view of each patient's data, meaning having all the patient data collected in a single registry or place to understand the patient continuum of care, can help the patients understand their journey and support the healthcare professional in designing the best treatment strategy for them. We can use individual data for the collective interest, for example, to evaluate the quality of services, as it was mentioned during the first panel. A person who has suffered harm has suffered it, unfortunately, but we can use this information to prevent further harm in the future. And as for screening programs, we as patients organization will have to educate the general population that is the target of the screening program by raising awareness on the importance of medical data collection and sharing, as maybe this topic is not so sensitive to them yet. In the screening context, in fact, sharing data can help us understand when a treatment truly is needed or avoid over or unnecessary treatments. So it's important for participants to understand the advantages of sharing their data. It's important for them to have this information. So by linking screening data to other medical data or personal data, for example, we can gain a lot of insight into individual and population risk factor or protective factor, which can be then analyzed, and we can design strategies to mitigate them, for example. So in general, we think that data should be used for collective good to improve health system and accelerate innovation. We are looking forward to the discussion about the European health data space, and we will be working with our partner organization to ensure that health data governance incorporates patient perspective from the outset. Because obviously data is not a collective good when someone uses it for profit or to discriminate.
Thank you very much, Mariana. And this is the moment where I can take questions from the audience. So please feel free to put your messages in the chat if there's a question that you want to ask. Andre, if I could come back to you, because I was really struck by what you said. One of the big challenges we have in healthcare is that we tend to measure and reimburse by inputs. So X number of examinations done, X number of tests done, etc. And that makes sense. That's what we measure because that's a form of performance and that's how we bill everything. But what you're talking about is outcome measuring. And this is, I think, the broader challenge we have all across healthcare. And you illustrated it so well. You don't know if a sort of a figure, a number turns up and that was in screening. And we don't know if any of those numbers correspond to a later number in a colonoscopy. We don't know if any of those numbers correspond to a biopsy, and we don't know if any of those turn into treatment. But we know how many of each of those different interventions happen because we bill that way and we structure it. So I don't know if there's a magic way of fixing this because it's clearly a structural problem in healthcare. But Andre, do you want to comment on this? Is it a mindset and cultural problem? Is it to do with the way the incentives in the system are designed?
I completely agree with you. I think the incentives are like these. And also I think that the fragmentation of the data, right? Even though all those health system providers can know who they did the colonoscopy on, that data is not linked, right? And that brings also a different issue is that, let's say that on those colonoscopy they might not know how many were for the first test screening versus somebody that was repeating colonoscopy, because they did a colonoscopy, they saw something that they could not do the procedure at that day. So they come a month later to repeat the colonoscopy for some reason, right? Or if that's someone that's following a colonoscopy from a year before. So there's so many that you all put together, the diagnosed colonoscopy with the screening colonoscopy. So you replicate a lot of different patients, even though all the health system knows who they did it to, and mostly countries have a unique identifier for any individual in the country. So it's feasible, the linkage. It's just not happening for many reasons. And that's make things very difficult when we want to measure the screening pathway, as we have been talking about.
Thank you. We have a question that may come back to you, Andre, or to others, from somebody called Arthur Schroeder. Says that he's in his structure. It's called formedbox.eu. It's a personal genetic locker, and they work with a biomedical passport where the bioprofile is the basis of research, and that's in accordance with the GDPR. And he's saying, how can we help? How can we support? Because they seem to have a solution there. Is there anything that you can comment on that, this idea that people would have their own personal biogenetic locker that could then be opened and shared for research?
I don't know about this specifically, and I'm definitely going to look at that. But I don't know, and I guess Mariana had commented a little bit, right? That the GDPR, somehow how they interpret it, we are also taking out the individual willingness to be part of the solution, right? We are bringing something top down, right? That we define, this is the basis. That's what we need to follow. And there is countries in EU have been interpreting these very, very differently. Some countries are able to completely link all the data. Some countries say, no, we cannot share the data, not think about, and this is harming the individual, not only the programs, but even the individual. So I guess we need to bring that up, that, you know, individuals must have a voice on which kind of information they need to share. But I don't know specifically about this, but I'll look for it.
Thank you. Mircea, maybe I could come to you with a question, which is, we heard about, Andre, the challenge of kind of linking together various bits of data, but you're in the pilot phase in Romania. What can you tell us about your approach to data quality? How do you control the data, particularly in that pilot phase where people are still working out how to do all of this, so that the results of your pilot phase are so convincing that it can go to a national screening program? So obviously quality control is really key in this early stage, but it's a new process, so people are still learning. Can you give us some insight on that?
Yes, I could make some comments. Actually, the register as it was designed provide all the data for one person, from the invitation until the final pathological diagnosis. And moreover, it provides also the next evaluation according to the pathological and endoscopical result, or according to the negative fit test. So provide also the data for the second, for the next providing of the second fit test after 2 years. So the traceability is very clearly provided in the register. It's a unique register. We have 4 regions, 4 regional pilots, but the register is only one with for the moment 4 regional components. It will be 8 regional components because we have 8 regions, and from 2024 we will go further with pilots in the other 4 regions, and we go to the extension of the activities within these first 4 regions which were already piloted. So the quality indicators are provided by the reports of the register. Is designed like this. We are very, let's say, proud about how it works for the moment. Of course, we have only 80,000 screened people within the register, and of course, people invited and not coming back, and people already having the fit tests and not coming back with the fit tests, and so on. So all the quality indicators are present there on the register. We just could extract them at the National Institute of Public Health, which is the guardian of the data presented in the register.
Thank you. Rema, maybe I can invite you to share some perspectives. You mentioned that some of the challenges about, sometimes people refuse the colonoscopies because what's being on offered. Maybe you could pick up on this role of public information. You want to go from opportunistic to population screening, but we heard earlier that part of that is population needs to understand it, needs to accept it, to be aware of the risk and realize that it's important for them to participate. Are there any sort of stigma or taboos, or do you think this would be widely accepted for for the population if it was offered?
So, okay, we have here we have to split the problem. One of the biggest problem is that we need to be very active in educational program. I mean, for population. The other part where we have to be very active and to explain them, it is GPs in regions. It was for some years a program, 2 years long, we organized trainings for GPs. But I'm sure that it's not enough. We have to do it every year. And I think that it's very important to explain the general practitioners. I mean, in regions, in village doctors, in Tbilisi, in insurance companies. We don't have only push them and tell them that they have to send the people to the screening units. I think that it's very important that we have to explain them why they have to send the people, the population to screening unit, that what are the benefits of screening. From the other hand, we have the other problem. For example, that the screening program is free of charge for the population. It's covered, all expenses are covered from government, from state budget. But sometimes the state budget don't enough. And the providers, most of providers of screening units are private units. In many cases, for them, it's not very effective. I mean, cost effective to provide screening program. It's the other biggest problem. I think that, for example, the Georgian team, I mean, this Georgian Society of Clinical Oncology, we are very proud that we are a part of consortium of Eutopia consortium, and in frame of this excellent project, we established, and from May next year we have to begin to work in Lanchut, West Georgia, a small part of West Georgia. We establish a new cancer unit, cancer screening unit, and in this place we want to try to begin organized screening. We want to organize many trainings, educational trainings for population, for organized women groups, like teachers at school, like children at school, to explain them that they have to push their family members, their parents, to come to screening unit. It's very needed, and it works. In our experience, when we organized, for example, some talk show in the TV channel, next week was dramatically increasing the number of people who come to screening units. After them, it goes down. It means that we have to do it every day, every week, every month. And we have a good idea. We want to ask our government that once every month, one of them have to come to screening unit with their PR service of ministry, of different ministers with their ministry staff, and do a small, like a sujet, like I don't know what, like a very small, some TV, don't movie, but I don't know how to call it, and to put it on TV channels and to tell the population that they have to come to screening units. It's very important, and because I think that we need more money for this popularization. It's needed. It's needed because, to be honest, in many cases, the GPs don't have so deeply knowledge what is screening, why it is needed, and sometimes it's not very comfortable for them to tell that they don't have big knowledge. But all of them are happy to participate this educational. I think we have to go this way, but it's needed some extra funding for this.
Thank you for that, Remy, and thank you for the members of the panel to explore some of the things. Andre, did you want to say something? No.
Yes. Yeah.
May I have just?
Oh, sorry, Carlo. Yeah.
Yes. Hello. Please go ahead, Carlo.
No, sorry. Just a comment on the discussion. Of course, the issue of funding is a crucial one, and as it is a crucial issue, the need to promote screening, to public campaign, and to increase awareness of health professionals, in particular general practitioners. The issue of difficulties in having in connecting data, linking data to the different phases of the process is in fact crucial. With the screening process has different phases, but they are not often linked together. And what is supporting the link is not only the need of implementing some interoperable software, let's say, or IT system, but also to have an organization which is in charge of following the pathway for each for each person in this coming the screening process. As it was started in Romania, for example, you need to have someone taking care of the flow of the patient. If you have an organization supporting the flow of the patient, you will also be able to get the data from this pathway, because you are aware of the process, the progress of the patient in the flow whenever progress is needed, if you need an assessment, if you need treatment. But as long as you have an organizational infrastructure which is ensuring that each patient entering the screening will have the appropriate offer of screening, assessment, and treatment, then you will also have the data. But it's crucial to have to implement these within an organizational infrastructure, a population-based organized program, because otherwise each step is not linked, is not connected. And within this process, it's important to explain to the patient why sharing the data is important. As Mariana Vitaloni was mentioning, the experience of each patient is important to improve the quality of the next one who is coming in the screening, and also for the experience in the next round for the same patient who is coming back. So sharing the data is important to protect and to improve the health, the care of the patient in the process.
Yeah,
thank you.
And Tamsi, if I can add just one quick comment, you know that like part of our mission is to raise awareness. That's why we are also celebrating this summit, right? And for patients or patients organization have a very important role in the mission of raising awareness on the importance of screening programs, and for people to participate, and also for healthcare professionals to inform general population on the importance of participating in a screening program. I think that Zorana will mention that, but every March we are raising awareness on the importance of participating in screening programs, and especially organizing a campaign to reach the general population and to let them know that this is key to prevent and to fight colorectal cancer.
Excellent, thank you. Andre, do you want to say something? Because if not, I'll close the panel, but please go ahead.
Yeah, it's very quick, but I think Carlo and Mariana touched. Because I said, the participant should have, the possibility of allowing sharing the data, but it's very important for them to understand why, and that should be something that we should empower them, and this should be informed decision, informed consent, not something that, they need to understand why they would do it. I just want to complete that part. Thank you so much.
Thank you, and thank you very much to all the members of the panel, to Carlo, to Mircea, to Rema, to Andre, and to Mariana. Thank you very much. We're now going to move to our third panel, and we're going to look at early onset colorectal cancer screening. And the question we're going to be asking is, should population screening begin before the age of 50? Now, if you remember in our first panel, I think it was we heard from Iris, who said that we're starting to see younger populations, we're seeing, and we don't understand yet why. but we're seeing patterns of that. So this raises the really interesting point. And the first person who's going to present is going to be Professor Elena Stoffel, and she is the Associate Professor of Internal Medicine and the Director of the Cancer Genetics Clinic from the University of Michigan, USA, and I think joining us across the pond in a very early time. So thank you very much for getting up to join us. And also joining me on the panel, I have Professor Julia Martina Cavestro from Gastroenterology and Gastrointestinal Endoscopy Unit in the Vita Salute San Raffaele University and the San Raffaele Scientific Institute in Italy. I have Professor José Perea, the Principal Investigator at the Institute of Biomedical Research of Salamanca in Spain, and Andy Carlan, the DiCE Patient Advisory Committee member and Employee Benefits Specialist and a colorectal cancer survivor from Romania. So welcome to our panel. But let me first pass the floor to Professor Elena Stoffel to take us through the pros and cons of early onset screening for the under 50s.
Well, thank you so much. I really appreciate the invitation today to be part of this really important summit. And I think that by way of introduction, can you see my slides? Okay, great. Okay. So by way of introduction, I have no conflicts of interest to disclose. However, what I must disclose is that I am a gastroenterologist in the United States. So what I am presenting to you largely reflects the goals of what the United States has decided to do with regards to their cancer screening. So to start off, the topic of today's debate is whether or not to start screening for colorectal cancer in individuals under age 50. And as you may be aware, multiple societies in the United States have recently made the official recommendation that colorectal cancer screening for average risk individuals should start at age 45 instead of 50. The first group to make this recommendation was the American Cancer Society in 2018, and this qualified recommendation was met with considerable debate. However, in 2020, the U.S. Preventive Services Task Force issued a provisional recommendation for grade B to lower the screening age from 50 to 45. And then shortly thereafter, the American College of Gastroenterology and the U.S. Multi-Society Task Force followed suit in recommending that for average risk individuals, age 45 is the new 50. So why did this come to pass? Well, review of data from the US SEER registry has demonstrated that while colorectal cancer incidence and mortality have decreased for individuals over age 50, the rates have actually increased for individuals under age 50, such that the incidence of colorectal cancer for individuals under age 50 has increased by 45% since 1992. And presently, 1 in every 10 colorectal cancers diagnosed in the United States affect individuals under age 50. This graph actually reflects a really distressing trend in increasing colorectal cancer incidence rate ratios based on birth cohort. And what Murphy and colleagues did was they actually looked at CRC incidence rate ratios based on the year of birth and demonstrated pretty strikingly that individuals born after 1960 have experienced a dramatic increase in cancer risk, such that the risk of colorectal cancers among millennials is approximately 4 times higher compared to the risk of their grandparents at their same age. So the U.S. Multi-Society Task Force, which is the composite organization that reflects many of the USGI, the American Gastroenterological Association, the American Society for Gastrointestinal Endoscopy, and the American College of Gastroenterology, made a recommendation this past year that suggests that average risk colorectal cancer screening begin at age 45. They justified this recommendation based on the observation that there is increasing disease burden among individuals aged under 50, emerging data that the prevalence of advanced colorectal neoplasia in individuals ages 45 to 49 is approximately the same as that observed in individuals aged 50 to 59. And then finally, modeling studies that demonstrate the benefits of screening outweigh the potential harms and costs. So diving into these a little bit more deeply, there were 2 studies published in the past year that looked at colorectal neoplasia that we saw in the past among 50-year-olds and compared it to what we see in the present between 45 and 49-year-olds. And as you see here, compared to 1992, the incidence of colorectal cancer in individuals ages 45 to 49 is now virtually the same, if not a little bit higher than for the age 50 group. And similarly, studies looking at the prevalence of adenomas or advanced adenomas demonstrate that the incidence of, or the prevalence of these is virtually the same in the individuals age 45 to 49 as for individuals age 50 to 55. So what about the modeling studies? The U.S. Preventive Services Task Force relies very heavily on modeling for their recommendations. And in this really comprehensive study that looked at a number of different possible screening modalities, they identified that across the board, any type of colorectal cancer screening is going to save lives. And with regard to quality effectiveness, lowering the age of screening from 50 to 45 is resulted in approximately 22 to 27 additional life years gained, albeit at the cost of additional colonoscopies. And this additional study that was published by Yuri Laudovan and colleagues in gastroenterology actually compared the various strategies of colonoscopy, lowering the age of colonoscopy to age 45 compared to keeping it at 50. And then in the second 2 columns looked at the comparable effectiveness of screening starting at 55 or screening starting at 65. And as you can see in the first column that looks at the comparison of starting at age 45 compared to starting at age 50, there would be a lot more people screened. However, there would be a lot more colon cancers prevented and colon cancer deaths prevented, albeit at a huge cost. And I think the important thing to look at here is that it depends on how you screen. If you decide that you're going to screen 45-year-olds with colonoscopy, this is going to result in considerable more cost, approximately $33,000 per quality adjusted life year saved. But if you screen them with FIT, it's much more cost effective at a cost of $7,000 per quality year of life saved, at a benefit of about 11,000 colorectal cancers averted. But again, the cost is additional colonoscopies, and approximately 10 million colonoscopies needed at a cost of about $10 billion. So I think in terms of talking about the pros and cons of screening at 45, we know that if we were to lower the screening age from 50 to 45, we would prevent approximately 1 death per 1,000 people screened. And we would only need to screen 28 young individuals to find 1 advanced neoplasm. On the downside, we know that this screening at age 45 will not prevent all of young onset colon cancers, since half of individuals with young onset colon cancer are diagnosed younger than age 45. And the other downside would be that this would expand the screening population. In the US, it approximately increases the screen eligible people by 22%. And obviously that comes at a cost of additional screening tests and colonoscopy resources. So I think I look forward to Dr. Cavestro's rebuttal because I think that we can agree that the incidence of colorectal cancer is rising among individuals age under 50. We also can agree that colorectal cancer risk assessment should be performed for every individual, and this should ideally be happen even before age 45, since there are many individuals who have a family history of colorectal cancer or other comorbidities that would require starting screening before age 45. And certainly, we absolutely agree that any patient who exhibits red flag symptoms, such as rectal bleeding, should be promptly evaluated with colonoscopy, since unfortunately we know that many of these individuals are often told by their doctors that they're too young to develop colorectal cancer. So I think that in the United States, the trend this year and the consensus has been that it is recommended to consider colorectal cancer screening starting age 45 instead of 50. But I look forward to Dr. Cavestra's response. Thank you very much.
Thank you very much. And again, it was very interesting to see your presentation, but quite shocking figures looking at the risks of millennials being 4 times higher than their grandparents at that age. So clearly there's something that needs to be explored there in that. Julia, can I invite you to please share your screen and to share your presentation? And you're going to, if we just heard there a sort of a balanced assessment, but on the whole for screening below 50, I think we're going to hear from your side a balanced assessment that comes down on the side of the cons of that. So please, the floor is yours.
Good morning. I'm very glad and I thank Digestive Cancer Europe to give me the possibility to speak together with Dr. Stoffel about this very important topic. And yes, I can tell you that we agree, me and Dr. Stoffel will agree on the last slide of Elena. And indeed, it is, I should be concerned, the screening, and this is strange to me because we are indeed actively involved in screening promotion and awareness campaign, and this was a huge plastic column that was placed just in front of our hospital. And we—
Sorry, could I just interrupt? Could you put it on presentation mode, because otherwise the slides are too small for us to see, because we're seeing only half of your screen. That's better. Wonderful. Thank you. Now we can see everything. I think we've lost the sound.
I'm sorry, I have
Yes.
plenty of problems. Anyway.
Now we can see your screen, but we needed to hear your voice as well. There we go. There you are in a plastic colon in front of the hospital.
Plastic colon just in front of my hospital. And we were actively involved in an awareness campaign on the importance of colorectal screening. Okay. But I cannot go. Okay. So screening means to sift by passing through a screen. From an old Dutch word for a tool used to separate coarsers from finer particles of loose materials, which clarified the main idea behind screening, that is separating the sick from the healthy. Indeed, we have cancer screening can be divided into 2 different concepts: preventive screening and early detection screening. Preventive screening tests aim to detect benign cancer precursors. On the other hand, early detection screening cannot detect the benign cancer precursor, but it aims to detect invasive cancer at an early stage. And as concerned early onset colorectal cancer, well, we are not sure what we are looking for. Maybe both of these aims can be searched for. So in contrast to care for symptomatic patients, screening targets healthy individuals with no clinical signs or symptom of disease. Therefore, it is especially important that its benefits outweigh its harms. A general framework for benefits and burden and harms of screening should be considered before recommending any screening. A variety of tests are available for colorectal cancer screening. To date, only guaiac-based fecal occult test and sigmoidoscopy have been shown to reduce the incidence of colorectal cancer and its mortality in randomized trial. However, the most applied tests today are the fecal immunochemical test and colonoscopy. Clinical guidelines have become important tools to facilitate evidence-based medicine, but they may also have negative effects and pose ethical challenges. As Dr. Stoffel told us that recently some US guidelines, such as those from the US Preventive Service Task Force and the American Cancer Society, have changed the recommendation starting age for screening to 45 years. This guideline based their recommendation on estimates of benefits and harms from microsimulation modeling. Models rely on several assumptions, but the validity of the modeled outputs is indeed uncertain. It is important to acknowledge the uncertainty when recommendations are based on modeling. Moreover, we have to say that screening leads to a large clinical benefit, some for many, but it exposes others to burden and potential harm. Colorectal cancer screening is not a one-time event, rather it results in follow-up colonoscopy and surveillance for many individuals. People may value the potential benefit and harms differentially, and some may reasonably decline screening. There is currently no estimated threshold of what magnitude of benefit people would want to undergo screening given its harm and burdens. Although, as Dr. Stoffel told us, although the relative risk of early onset colorectal cancer is increasing in the United States, the absolute incidence of early onset colorectal cancer is still moderate, reaching 3.1 every 10,000 in the 45 to 49 age group, compared to the 58 every 10,000 in the 50 to 54 age group. Thus, the true risk in adult aged 55 to 59 years is likely closer to the risk in adults aged 50 to 54. More importantly, however, is the increasing incidence rates for adults aged 40 to 49, that is 1.3%. And it is more than twice than of adult age 50 to 54, that is 0.5, suggesting that the risk for younger cohort will carry forward into the group age 50 to 54 age. Moreover, we have to acknowledge, coming to Europe, that we really need some good epidemiological studies for these patients, because we have this paper telling us that the mortality for early onset colorectal cancer in Europe is not increased. We also have this very important paper. This paper is based on online database from registries. from Europe registries, and this paper tells us that also in Europe we have an increasing incidence in early onset colorectal cancer. But when we look at cancer registry nationally, this is the cancer registry for Netherlands, this is from Italy, we see that we don't still see this increase in early onset colorectal cancer, except in Milan. This is my city, and in my city is really clear that we have an increase in this cancer. So something is going on also in Europe, but we really need a very good epidemiological studies, not based on online database. Dr. Stoffel already showed you this slide, so I will skip it. This is not optimal, but it is a first step, because most, as we said, most colorectal cancer screening programs recommend screening to everyone older than a certain age, and do not consider individual risk, cancer risk, as Dr. Stoffel told us. This more recent colorectal cancer guideline proposed the introduction of risk and benefit thresholds for recommending for or against screening. The proposed threshold is based on balance of absolute benefits and harms, and used an expert and patient panel to provide guidance that on what most people would choose is not optimal. It is a first step. Moreover, this guideline, this recent guideline from US tell us that we have a strong recommendation for screening between the age of 50 and 75 years, but this recommendation did become conditional recommendation if we consider the population from 45 and 49. So I would like to thank for the opportunity to speak with you and to try to understand what is better for our populations.
Thank you very much. That was really interesting to hear your perspectives as well, and to see that, you know, I noticed what you said is that, you know, screening isn't a one-off thing, it's a continuum, and it triggers colonoscopies and it triggers further things. So the screening itself it needs to be looked at in that broader perspective. So very interesting. We're now going to hear from Jose Pereira, looking at what are the factors that are linked or associated with the onset and progression of early onset colorectal cancer, because we heard, I think, both from Elena and Julia that we know something's happening. We know that certain parts of the young population are getting increased rates of colorectal cancer, but we haven't really understood what or how. And I hope that, Jose, you can give us some answers. The floor is yours.
Okay, thank you very much. First of all, I would like to thank DiCE for inviting me for this great symposium and specifically for this panel. So the idea of my presentation is put together both presentation, pros and cons, and thinking about what can we do to screen early onset colorectal cancer nowadays. So the idea is take on account all the risk factors for early onset colorectal cancer and think about maybe develop some strategies to define something like a precision medicine in colorectal cancer in the youth, like precision screening or screening specifically for some cases. So why is it again telling the same direction that incidence in early onset colorectal cancer is increasing, but it changes if we focus depending on the countries. Some countries are increasing completely, but some others, specifically in Europe, are not so, the incidence is not so high. So I think we should define strategies for screening. which topics which we should take on account to develop maybe those strategies. So I think we should think about predisposition. Some individuals are predisposed to develop early onset colorectal cancer, and together with the exposition to some elements that could give them a risk for developing early onset colorectal cancer. From the first part of it, predisposition, we all know that some cases within early onset colorectal cancer are developed by hereditary forms. More or less 20% of cases are developing because of germline mutation in some specific genes, and half of them are linked with Lynch syndromes. That is one of the points of predisposition, but also in recent years it has been shown that some SNPs regarding some polymorphisms in some genes are linked with the risk of developing early onset colorectal cancer compared with late onset colorectal cancer. So is that in some cases it has been developing polygenic risk scores to stratify the risk of developing early onset colorectal cancer. That is predisposition. Thinking about risk factor and exposition, we all know these factors are related with colorectal cancer as a whole, but we should think that specifically obesity and mellitus diabetes, it has been linked more frequently to early onset colorectal cancer. So there are a lot of environmental and lifestyle related factors linked with early onset colorectal cancer. This is very interesting because the risk factors are linked with early onset colorectal cancer, but we should think about something like we can define as geographical disparities. This is a study that we have sent for published, and this is a study in Spain. This is colorectal cancer related deaths, and as we can see in the slide, all the areas are completely different if we think about sex and age of onset. So specifically, the death related with colorectal cancer are different if we take on account the geographic side of the diagnosis, and this link with the influence of the different risk factors, environmental factors that are different if we think about geographical side. So focusing on the talk and the main topic of the talk, if we define the screening focusing of risk factor, I think we can define 3 levels of this screening. The first one, of course, are the hereditary forms. We all know Lynch syndromes, polyposis that are defined guidelines for those cases. The second level will be those high-risk population. That this is defined because of the colorectal cancer family history. We all know that there are some guidelines that take the screening not from 50 years old, but decrease to 40 years old, depending on the first degrees relatives, the age, the number of degrees, and this is the slide showing how the proportion of early onset colorectal cancer that could be prevented if we fulfill the guidelines. This is specific for the USA. We see in the slide that there is almost a 16% of cases that could be prevented if the guidelines are fulfilled, specific not from hereditary forms. And this is a work that we have recently published in British Journal of Surgery. And this is a study that we have developed in different countries in Europe with a total of cases of 846 cases. Those are sporadic cases, and if we take on account the guidelines in the European Society of Endoscopy, gastrointestinal endoscopy, only 5% of cases could be prevented if we fulfill the European guidelines. So again, another disparity, because if we see the USA guidelines are more flexible and the European cases are more restricted. Finally, the third level will be the average risk population. We see that if we take apart the hereditary forms, the family history forms for colorectal cancer, Now we have a 75% of cases of early onset colorectal cancer that nowadays are not screened. So those population is maybe could be the more important just for research to explore which markers could be developed in order to define population in risk for this specific population. And what we should do exploring, talking about research, I think all the things that are related with liquid biopsy, with for example, microbiome, in order to define probably molecular markers that could maybe define this specific population in risk of developing early onset colorectal cancer. Finally, it has been told in the previous talks. Not only screening but also prevention, secondary and tertiary prevention. We should think that most of the patients that are diagnosed of early onset colorectal cancer have got symptoms. They go to the general practitioners, and we should think about people younger than 50 with all the symptoms that are related with colon. Maybe we should put in one of the first places the early onset colorectal cancer to undergo colonoscopy for those patients. Finally, a summary, I think thinking about the screening for the population younger than 50, we should think about maybe stratify the risk of those patients, thinking about different risk factors as familial history, as for example, all the SNPs that are related with the risk, maybe the risk factor that can be linked with those patients, diabetes, etc., and then develop stool blood markers just to define those people that are in risk of developing early onset colorectal cancer, and those specific and then define for them strategies, or for example, some strategies for screening those specific subpopulation within people younger than 50. That's all. I thank you very much for your attention.
Thank you very much. That was, again, very interesting, very useful, and gave us a lot of food for thought, particularly understanding there's a proportion that's linked to genetic areas and a proportion that could come from other areas like lifestyle and environment, and how we could address that and do perhaps some more targeted screening. I'd now like to invite Andy Carlin to share from a personal perspective the experience of an early onset diagnosis of colorectal cancer. Andy, the floor is yours.
Thank you. Hello, everybody. Thank you, Mariana and DiCE, for the opportunity of telling my story. I'm honored to be here, and I hope that this will help raise awareness about cancer risk in young population. My name is Andy. I'm 39 years old. I have two wonderful little daughters, and I was diagnosed with stage 3 colon cancer at the age of 36. I used to be a blood donor for a long time and tried to help as many people as I could, until I was rejected at the transfusion center due to my low level of hemoglobin. They sent me home to get some sleep and recommended me that I should see an internist for further investigation. They thought initially that it's just a severe anemia due to low quality food I was eating back then, lots of stress, lack of sleep, and too much work. So I was recommended more blood tests, an ultrasound, but also a colonoscopy. Still, nobody explained to me the role and the importance of the colonoscopy in early diagnosis of cancer. So I did a blood test and I did the rest of the tests, but not the colonoscopy. I was too ashamed. I was too scared to do it. And on top of it, it was presented to me as just one of the many tests that I should get. So I delayed it as much as I could for more than 5 months until the pain became too hard to manage. And that was when I found out at 36 years old that I have stage 3 colon cancer and that I need an emergency surgery and 6 months of chemo. The second bad news was that if I have done the colonoscopy sooner, I would have had the chance to catch the cancer in stage 2 or earlier when it could still be curable. It was very difficult for me to accept this diagnostic and to trust the doctors around me, as they were arguing between themselves about my treatment line. So I asked for a second opinion, and then another and another, until I had 6 second opinions from 3 different countries before I started the chemotherapy. I decided to go back to Romania for chemo, and that helped me a lot because the support of friends and family had a tremendous role in my recovery. And what I want to say is that this is something nobody should ever face alone. And this is, I'm not sure how important this sounds to everyone, but it is extremely important. I was not well physically or emotionally, so I needed psychotherapy, nutritional advice, physiotherapy, kinesiotherapy for a long time, all of it paid by myself. The state here in Romania, the state insurance could cover some of these services, but on such a low level, and it's such a hard way to access it that I wasn't able to really use it, so I had to pay from my pocket. It was a very long, it is a very long, expensive and painful journey for me and my family, but I have a lot of support from my friends and colleagues, which matters a great deal. As stated before already, colorectal cancer screening and prevention are extremely useful, but one of the most important information I learned in my search was that first-degree relatives of patients with colorectal cancer should start screening by themselves 10 years before the age their relative was diagnosed. In my case, my little girls should start screening themselves at the age of 26. Right now, their only option is just keep that in mind and be responsible when time comes, because there is no screening program for people in their situation. There are a number of things that young people can do and are highly recommended. Take care of themselves and their lifestyle, both personal and professional. Be responsible about what they eat, drink, or smoke. Be aware of the signs their bodies give them. I think all young people who keep these 3 things in mind should be on the safe side. I mean, don't be a hypochondriac, but go see a doctor when something's wrong, like stomach pain, which is almost constant, frequent diarrhea, constipation, or the feeling that the bowel does not empty all the way, inexplicable weight loss or gain, and extreme fatigue. I mean, extreme, which means on a daily basis. Also, concerning the young population, I think the doctors should be more inclusive in terms of cancer risk. My personal experience is that many doctors still see colorectal cancer as an old people disease, which obviously isn't the case anymore. And they rush to treat young people for irritable colon syndrome, anemia, gastritis, ulcer, and so on before they screen them also for cancer. And I've got to meet and guide quite a few young people diagnosed with different stages of colorectal cancer in the last 3 years with similar stories. Coming back to the young, there is a famous quote which says that so many people spend their health gaining wealth, and then they have to spend their wealth to regain their health. The downside is that health is perishable, and sometimes not even all the money in the world can help you as much as prevention and screening could have. So take some time, go see a doctor, and just confirm you're healthy once a year. Thank you.
Thank you very much, Andy, for sharing your story and also some learnings that other people could reflect on. And again, useful that you recognize that, you know, based on your risk profile now, that has implications for potential screening and risk profile for your children as well. So thank you for that. We already have some questions coming in on the Q&A, and I would like to perhaps pick up on this. We've talked about let me have a look. We've had a comment and questions, but let me invite. Iris has said we're talking about the issue of biomarkers, and Iris's question, I think, is to you, Elena, in the beginning, to say she agrees with using risk to drive the starting age of screening. However, the threshold recommended by the BMJ panel is 3%, which actually, if you applied it fully, meant we wouldn't start screening most women until the age of 65, which presumably is beside the point. So, Elena, are you able to comment on that one?
Yes, certainly. So I think that what I think we are all talking about is that each person's risk for colorectal cancer is not the same. And picking an arbitrary age to start screening is arbitrary, right? Because many people need to be screened before age 45. Some people may not may be lower than average risk, but we just don't have a good way of being able to know who's at lower than average risk, and we need to do a better job at identifying who's at higher than average risk. I think that the biomarker work is certainly in progress right now, but certainly at this point it's not validated for clinical use yet. But I think that that's where the field is heading. As Dr. Perea explained, I think that if we're using age and family history as the only two risk stratifiers right now, we could be doing better. And there are probably other risk factors and other blood or tissue or stool-based biomarkers that can help us more precisely identify who's in the higher risk category and who's in the average or even maybe even a lower than average category.
Thank you. And perhaps linked to that is Stephen Rowley's had a question say, are there any studies that look at the benefits of screening for early onset compared with promoting risk reduction? In other words, if I've only got a limited amount of money to spend, is it best spent on reducing risk, which might benefit the whole population, or is it best to look at screening for early onset, which might benefit a few people? And I don't know who on our panel has the answer on that. Jose, is this an area you can answer?
I think at this point that maybe would be more useful to educate all the population, young population, for good habits, exercise, not to get, for example, all the things that got sugar added, everything like that. So a good education in the young population could develop a lot of prevention compared with all the if we can develop a colonoscopy programs, because it could cost a lot of money. And maybe thinking about also the money, I think prevention programs could be more useful and more practical, because nowadays we know some of the risk factors that are completely linked with early onset colorectal cancer. So, for example, diabetes, all the excess overweight and something like that. So, focusing on that, in my opinion, I think it will be more practical.
Thank you. Does anyone else from the panel want to comment on that? Julia, your mic is open. Please go ahead.
Yes, I agree with Jose. I totally agree, and I mean, we really have to educate our young population and ourselves, because they do what we do. So, I mean, I am in a lucky condition because in Italy, for example, I'm thinking about the diet in Italy. We have a quite good diet, but the data from Milan is really surprising us, because in Milan, indeed, we don't have a Mediterranean diet. We have a Western diet because Milan is a very huge city, it's not a typical Italian city, and we have the increase of early onset colorectal cancer. So together with lots of other risk factors, diet, I think diet is very important, but the change has to come from us, from the older counterpart.
Thank you. And I'm very struck by some of the risk factors that you mentioned for early onset colorectal cancer are exactly the same risk factors that I sit in groups looking at cardiovascular disease, looking at other forms of cancer, even looking at mental health and well-being. So reducing alcohol consumption, reducing smoking, getting up and being active. So maybe there's a way, if we're talking about raising population awareness of risk, that can be integrated in some of the other broader health promotion campaigns that are being carried out. So make sure that when money is being spent on them, that the risk to early onset colorectal cancer is flagged, rather than maybe trying to do a specific new campaign. I'm interested in, we have a few more questions that are coming in. Mariana wants to know about the concerns about the overuse of antibiotics at a young age. Does that have a link? We've already got sugar as the big bad guy. That's very clear because of its link to diabetes and obesity and everything else. But interesting point being raised here about antibiotics. We know that we've got a problem with antibiotic resistance. We overuse them in Europe. We also know there's some links between use of antibiotics in very young children and obesity. So is there anything you can add on that? Does anyone want to pick up on that?
If you want, I can add something. For example, I think it's completely linked with microbiome because, for example, now I think there are two studies that have been shown that the microbiome population linked with early onset colorectal cancer is completely. There are some similarities, but there are more differences compared with late onset colorectal cancer and compared with healthy individuals at the same age. So, and this microbiome population is linked with possibly linked with carcinogenesis related with early onset colorectal cancer. So maybe there are again a higher use of antibiotics from beginning in the 70s, 80s. So thinking about this population now are the adults with 40 years old, 50 years old. So maybe there is a relation, but still it is not proved completely the relation with microbiome. But I think that is one way to think about the reason of the higher risk for early onset colorectal cancer.
Thank you. Elena, did you want to come in on this? Because I mean, you highlighted that quite startling statistic about millennials. I mean, this is very recent. The millennials are born, in the last 20 years, and their risk being 4 times higher. Do we know what that's down to?
So we don't, and I think that's what Dr. Perea was referring to, is that there are a number of hypotheses and a number of association studies, and furthermore, there have been some animal studies that demonstrate that if you actually change an animal's diet, so if you take an animal that has a genetic predisposition to polyps and you give them high fructose corn syrup, the polyps grow bigger and faster than they do in the animals that get just their regular diet. I think that the issue with antibiotics is also one of what is happening to in meat production, not only beef, but also chicken, poultry, and other meats where animals are given antibiotics. So maybe it's not necessarily the fact that that millennials are taking more antibiotics for ear infections, but rather that the food that they're eating has been raised with in the setting of antibiotics that changes the microbiome. And I think that the issue of the microbiome, I think, is one of the very, very hot areas to be looking at. I think one of the challenges is that the microbiome varies tremendously depending on what you ate the week before. But I think certainly what everybody's getting at is that the diet has changed since 1960, and that's one of the hypotheses. Is that if our diet has changed since 1960, maybe that's one of the reasons why we see more cancers developing in younger people.
Thank you very much. I'm going to bring this panel to a close because we've slightly overrun, but I thought it was a really interesting discussion. And as you say, the microbiome is an emerging hot area of research, and I'm sure there'll be many more insights that we'll be able to be discussing in the future. Thank you very much to Elena, to Andy, to Jose, and to Julia for sharing your insights and having this really interesting conversation. And as we complete this panel, I would now like to pass to Zorana Marovic, the CEO of Digestive Cancers Europe. This is, of course, our 3rd Colorectal Cancer Screening Summit, and organized by DiCE. So what is the role of patient organizations and citizen groups in helping to shape the path going forwards?
Thank you, Tamsin. So as many of you know, Digestive Cancers Europe is a proud successor to Europa Colon. And in that sense, our journey of raising awareness about colorectal cancer started nearly 20 years ago in 2004. And I would like to use this opportunity to thank all patients, all member organizations and partners throughout the years for working together, as well as to all of you attending this Colorectal Cancer Screening Summit today and supporting us in our mission to see fewer people suffering from colorectal cancer. So over the last 2 decades, as explained by several panelists, there were some improvements in the implementation of colorectal cancer screening programs across Europe. and CRC incidence rates declined. Someone might say not big enough, but as anyone who ever went through cancer treatment with their loved ones, and we have just heard the story from Andy, this is an improvement and an important step that was made. Patient organizations cherish every single digit in statistics as a success. And we know that this is a life saved, a family rescued from the aftermath of devastating and always too early death. So needless to say, we are still a long way to go despite all the advances, and we need to ensure that vast majority of citizens are screened for colorectal cancer across Europe. And that's one of the reasons why we are doing everything that we are. So our role as patient organizations, whether national or European, is to keep on raising awareness and providing support. And to do this, DiCE is working with European policymakers and have played a part in the production of recommendations and guidelines, which are under development, as you have heard, and should be finalized in 2025, which is pretty close, but still some 3 years to go. We also need to raise awareness among national policymakers in order for screening programs to be implemented locally. And we were pleased to note that the European Commission has allocated 38.5 million euros for the implementation of cancer screening programs in 2023 work program. This is, of course, not colorectal cancer specific figure, but nevertheless, a portion of that funding will trickle down for colorectal cancer screening. And as we see our role as a supporting one for our member organizations, we plan to work closely with them next year in ensuring that national health authorities and policymakers understand the importance of implementing colorectal cancer screening programs. Equally important, we need to raise awareness among the general public, which was mentioned several times today. So when they get their screening invite, they are not scared. Do not ignore it, but take part. And this is what we will keep on doing, not just in March for the European Colorectal Cancer Awareness Campaign, but throughout the whole year. And we are preparing for March 2023, our biggest campaign ever, to raise awareness among the general population about the prevention and early diagnosis of colorectal cancer. And we know that the support that patients, their carers, and families need and receive is often an afterthought. We will continue working to ensure that patient perspective is included in all policies that affect them. Nihil de nobis sine nobis, or nothing about us without us, is a phrase invoked by many movements and is at the core of our democratic societies. It also guides us in our work with all stakeholders. And when it comes to the medical profession, I have great trust in professionals we work with as part of several consortiums, as well as bodies such as the European United Gastroenterology and others that we work with and cooperate well. And my sincere hope is that in the years to come, the vast majority of citizens across Europe will participate in colorectal cancer screening programs. But in order for this to happen, we need to keep on working together. We need better data. We need greater awareness among general population, GPs, policymakers, improved screening programs, and we look forward to working with all of you. So over to you, Tamsin.
Thank you very much for that very inspirational message. And we very much hope that your wish can be fulfilled, that all of the population gets access to quality care and screening and is dealt with. To just give the concluding remarks of this really fantastic summit, I'd like to now pass the floor to Tit Albrecht, the head of the Center for Healthcare at the National Institute of Public Health of Slovenia. Do we have Tit online? Yes, I can see you. Hello.
Hello.
I'm passing you the baton for the closing words of this great summit.
Yes, indeed. Thank you, Tamsin. I think it has been an excellent event. I'm privileged now to be able to give my final thoughts, the conclusions, to propose the conclusions of today's event. I have to say that you gathered an impressive set of speakers and who delivered an equally impressive and important a set of messages for us to take home for our future activities. I would start by, of course, noticing that we had introduction speakers who were mostly politicians dedicated to the issues related to the digestive cancers. Then we heard from Andrei Ilbawi from WHO Geneva about the global perspective. And then I would maybe move to the first panel. The first panel, which was extremely interesting, notwithstanding some technical difficulties that Karen had, but let me go one by one. I would point out very importantly what Professor Lamstorp Vochelaar mentioned, and that is the focus on quality assurance. Whenever I'm ever invited on any discussion on screening or national cancer control programs, quality assurance and quality control are in the center of my recommendations. Without those, there will be little benefit, measurable benefit noted, even for the policymakers, not to mention for the professional community. I would also like to agree with her reinterpretation of the criteria for organized screening programs, that in the sense that they should extend to the population-based screening programs as well. And of course, there is an issue that she mentioned where we have to be realistic in trying to prioritize recommendations, not to ask too much from those who are only starting their journey. And we have heard of such stories that started recently or not so recently. Then, of course, I need to mention the presentation by Karen Nicol from the Joint Research Center, who spoke on the European Commission's initiative on colorectal cancer, which follows the series which was launched with the breast cancer initiative, and it will be much faster. We will see the outputs out by mid next year, some already in January. And of course, what is important about these initiatives is that they focus on new guidelines and quality insurance schemes, which is again going to be essential, if not only helpful, to the member states across Europe. He also touched upon the issue of GDPR that was dealt with by other speakers as well. I might return to that at the end. Then we had two examples, one very practical one by Dr. Sarkaria from the Cancer Society of Finland, who explained the new approach of the lowering of the margin for positivity and the challenges for the future. Of course, we always listen with admiration to Finnish experiences, given the extremely good coverage achieved, although, as she mentioned, they haven't achieved their own national final targets. Nevertheless, percentages that are above 70 are always impressive and require a claim. Professor Christian van Wagner discussed the socioeconomic inequalities, which are, of course, an important challenge in all screening programs. Namely, reaching out to the difficult to reach populations is extremely important, because we might miss on important segments of the population who will not receive the screening invitations and not avail of the possibility to be screened early and to prevent, to divert advanced disease or disease at all. He stressed that you have to know your constituents, and underserved populations need to be addressed in different ways. and sometimes it is the result of the lack of integration of health professionals. This will link my conclusions to the observations by Dr. Guamichava from Georgia, who actually spoke about the difficulties that they are encountering because of the lack of awareness among GPs about the importance of screening programs. While he presented their gradual dissemination of the 3 recommended screening programs, he also noted that most of the providers are private. Currently, the screening is only opportunistic and it reaches only about 5% of the population. I am sure that many of us would be very interested and motivated in helping Georgia to move this initiative further and to find ways of how to motivate both the population and health professionals to advance. Having said that, I have to say that I'm very pleased to hear about the advances in Romania. Romania, which was lagging behind both in the development of their national cancer control program, but also in the screening programs, has now made not steps, but leaps forward, especially in colorectal cancer screening. Linkages of data have been ensured. There are clear links to the National Cancer Registry, which is not always the case. There is a focus on the quality and the traceability is provided, obviously, by the National Cancer Registry, and 4 regions are included already and 4 are to be included. We heard in the continuation from André Carvalho from the CANScreen 5 project, coordinated by IARC. They are gradually advancing. They collected data from 8 countries. And I particularly note, and I claim that they are using numbers, not derived data such as key performance indicators, because this gives them the possibility to centrally standardize data. And this has already been the practice of WHO in the past. And it's the only way that you can really get clear comparability. Of course, there are complexities of the different elements of data and documents, and of course, also the different interpretations of the GDPR. Mariana Vitaloni spoke about the raising of awareness, both among the target population, the general population overall, which is important also for the conclusions or the reflections of the final panel. And of course, the role of the cancer survivors and of those patients who have actually been diagnosed through the screening programs is essential for the positive awareness and for the positive messages given to the population. This brings me forward to the discussion on the early onset of colorectal cancer screening, what the possibilities are. We saw 2, I would not say entirely opposed views from Professor Elena Stoffel from the US and Professor Giulia Martina Cavestro. And obviously there are some differences between the 2 approaches. Among others, also the use of colonoscopy, which from the experience of some countries in Europe, I namely remember because I have listened to those presentations in the past. For example, Poland, the acceptability of colonoscopy as the first line test for screening has not been very encouraging, not more than about 35%. This means that FIT is a much more agreeable test to start with, of course, in the populations that where it is suitable and the way it is administered. In any case, in Europe, we need more data to decide on the possible lowering of the start of the colorectal cancer screening program. Professor Cavestro clearly showed some very disturbing data from Milan. Nevertheless, these rates, as you could see from some of the graphs, I hope so, are much, in some cases, still slightly lower or are getting closer to the data for the 50 to 54-year-olds. Of course, we always have to balance the risks and the benefits in lowering the margins. And as we have seen, we need, as we have seen from the following two presentations, we need other approaches to reach those who actually occur even earlier than 45. And because we will not cover even lowering the margin to 45, all the populations, subpopulations who are at higher risk because of their polygenic risks related to the early onset of colorectal cancer, and of course also role of risk factors. I'm glad that we had a cancer survivor from the early onset cancer. Unfortunately, he didn't have an entirely positive story in the sense that of his struggle to get to diagnosis. Often the awareness also of health professionals that a younger person could also, of course, fall ill with the disease that we normally or on average attribute to the elderly populations is needed. And of course, the so-called outliers, the early onset cancers, need a more individualized approach. And I think we would all strongly vouch also for the individual assessments of risks in patients who have a positive family history and who have additional risk factors, as indicated by Professor Perea. I think I would stop here. I will do a written summary and provide it to the organizers in order to have something on paper, as we say, although today it is not on paper, but nevertheless, very impressed with the program and with all the evidence shown. And I thank everyone for your kind attention, also to my final words.
Thank you very much. What a great job you did of summarizing and taking us through the program. And I just want to remind our audience that all of the presentations that you saw today will be available on the DiCE website, as will a report, as Chitra said, which brings together some of the comments. So thank you for participating. We know there was a lot of really great material, but you will be provided with it afterwards. Thank you to the DiCE team for all their hard work behind the scenes and all the preparation and all the technical support. You made it wonderful for us to participate. Thank you all, and hope to see you at the 4th Colorectal Cancer Screening Summit, which will probably be next November. And in between, of course, we invite you to other screening and other promotion activities that DiCE will be taking care of. Take care. See you soon. Bye.